I don't know, babes. Not really.
All right, everybody. It's 6 p.m. Of course, in the interest of time, we're going to try and get started. I always encourage people to try and get in a little bit earlier. I think we have some stragglers tonight, but we're going to have to get started anyway. Tonight we have Dan Limmer. He is an accomplished author, has written multiple EMS textbooks, I believe 15 or something along those lines. That seems like a lot of books, Dan. He's been in
several
EMS
more than Mistovich, that's for sure.
Well, he's kind of a slacker. So Dan's been involved in public safety for more than 35 years. He's a frequent international speaker, conference speaker. He also owns Limmer Education and is on the EMS One editorial advisory board. We're real happy to have Dan with us today. We're lucky to have him. I appreciate you taking the time, Dan, and out of your busy schedule. I'm sure you're busy just like the rest of us.
Glad to be here.
Oh, thanks, man. Just like every other week, I want to, we like to touch on COVID-19. I'm glad our numbers are going way down, and that's a great thing. But still, guys, today, this is still no time to let our guard down with our PPE and everything. I'd also like to mention, I saw in the news a couple of ambulance crashes, one in Dayton and one in Madison, Ohio. If anybody is from those areas, I hope your friends and family are okay. And, watch those slippery roads, man. It's winter in Ohio. So take it away, Dan. He's going to be talking to us today on some end-of-life issues.
Kind of appropriate segue there. Let me see if I can share my screen here. Stand by. All right, now let me play this and, all right, you guys see my screen?
Yep, you're all set.
All right, you really don't need to see me. You got the Grim Reaper there, you should be all set. All right, my name's Dan Limmer, and yeah, I've been introduced, I think that's well. I got roped into this because I think Joe Mistovich, not like a book competitor, but like a best friend and a brother, and I'm happy to do anything for Joe and to get out, and also to talk about important issues. I've been a paramedic last July and coming up on 41 years, I guess. And, I kind of got to the point where I'd like to speak about things I'm interested in. One of those things is what happens when we are at the end. We have the concept of racing the Reaper, but we can't always win. We know we can't win. There's times there's dignity in saying we're done, but we're never trained about that in class. We're trained in ACLS and PALS and CPR and all these other things. Well, now we can call codes on the scene and do things, and we're not prepared for things like telling people that, he's dead. There's nothing more that we can do. I'm going to tell you a quick story while I got this nice title slide up here, is that this presentation came about. Now, while I was a paramedic, I'm still a paramedic, for 40 something years, I've been in police work most of my life as well. Really, I spent a lot of my full-time job. I spent a fair amount of EMS as a volunteer. So I was a cop and I got sent to this call for an unresponsive person. Now, most police go the other way when you see a call for any EMS call, but especially a working EMS call. So I pull up and I walk and I come in the door, and in the back of the house, I see a skeleton of a person lying in a hospital bed. And the woman meets me at the door and says, "Hospice isn't here, and they never told us what to do now." And I said, "Okay. So tell me what's going on." "Well, he's got cancer, and we think he's dying, but hospice is 30 minutes away." So I'm like, "All right, well, let's go take a look." So we go in, and this guy is 80 pounds, if he's anything. And he probably, look at the pictures around, he was 220 before, and he's full of cancer. He's in a hospital bed. And I look at him and I see his breathing, and it's agonal. So I'm thinking, well, people do sometimes come back. They said, "Well, do you know how long he has?" Now, fortunately, me being a cop, also being a paramedic, I was a good person to have there. And I said, "You can never say for sure, but I think we're looking at minutes and not hours." And they start crying. I said, "Does hospice talk to you about this time?" And they said, "No." And I've had two parents die of cancer and, gone through it. Seen a lot of death in, 40 something years. And I never shied away from it. And I said, "Well, right now is a time while he's still breathing, we'll have a chance to say something." And a lot of people believe that he will hear or feel it. If you love him, or if there's a message you want to give him, now is the time. So they all gather around the bed. I'm at the foot of the bed. The family's on each side of the hospital bed. "Oh, Grandpa, we love you. Dad, you've been an amazing dad." And they all said all their stuff, and they're crying. And they paused. And I said, "Has hospice talked to you about the last minutes?" And they said, "Well, no." I said, "Sometimes the person wants to hang on to be with you. They're worried about you. This is the point where you say, 'I know that you can't stay with us. I know you're in pain, and it's okay to go. I'll be okay, but only if you feel that.'" And so they're all around the bed, and they're nodding their heads like, "Okay, we got to do this." And they're crying. "Dad, Grandpa, we don't want you to go, but we're going to be okay. We love you. We know it's your time." And they're all looking at him, and bam, he died. I mean, just like that. I'm like, holy shit, this stuff works, And so I said, "Okay." I said, that was it. Now we're going to wait for hospice, and they'll call a funeral home and do things and explain some things. And it was at that point I realized that, now, I don't know how exactly I choreographed that so well, but in doing this, I said to myself, we look at death and dying as something we do on test questions or some touchy-feely stuff that we have to do or have to get tested on or is against what we do, because we're always trying to save the patient. But the truth is, we're doing ourselves a disservice for the family, for the patient, and certainly for our mental health as we go on. And, we're conditioned like this, right? We're conditioned to race the reaper, right? That all the things that we do and see have to do with this. And I'm not saying there's anything wrong with it. It's a beautiful work right there. And you do that and you can be proud of what we do, as long as you don't take it too seriously, as long as we don't get to the point that we are incapable of dealing with death or ignoring death or putting our emotions about death off to the side, because it's inevitable. Now, Joe knows I'm kind of a crazy old Buddhist. I'm Buddhist, except for the drinking and killing. And, to a great extent, that I have come to the point that death is inevitable. And that when you do that, you look at life differently. I'm not trying to make this a religious thing at all, but the truth is we're young and invincible. And then we're middle-aged and we have a little bit of reality, and we're older and we're in denial. And I think there's a certain part about living that we miss. And not only is it something that we have very much in our head, we have our own formed opinions. This is very big in the literature. Being mortal, medicine, and what matters in the end. Okay, Atul Gawande's got a lot of books out there. How We Die, a National Book Award winner. I think you know the end. All right, I can't see all, but hopefully you're getting the sick jokes here as I go along. Dying Well, right? Peace and Possibilities at the End of Life. How about this? When Breath Becomes Air, a book about a neurosurgery resident who gets cancer. And he's writing this book as he goes on. They want to have a baby. He's married and they want to have a baby. And he's got the fact that he's not just a resident, not just a surgery resident. As I recall, it's a neurosurgery resident. And in doing this, he's looking to get to the end and to finish this book and to wrap this up and send this out. He dies before he can finish it. His wife writes the last chapter. And it's not incomplete as that, it's real as that. Because there is certain inevitabilities and there's certain things that we can't control, no matter how much we try to race the reaper. And then ultimately, the book that we all talk about, or at least talk about, denial, anger, bargaining, depression, and acceptance, on death and dying, what the dying have to teach doctors, nurses, clergy, and their own families. Elizabeth Kubler-Ross, I think was brilliant. I think she was way ahead of her time. I think largely we were behind our time in what we thought about this. But this started a conversation for generations, this text. Now, occasionally you'll see things. If you want to find out all the psychological issues that physicians can have, you can read Kevin, MD. This is more of a Medscape article. And Whitney Yu, a physician, started the baby girl lying in the warmer in the NICU. She wasn't alive, and I just couldn't stop crying. For the first and only time in her career, she was an assistant professor of obstetrics at Northwestern University. She couldn't do her rounds. She lost babies before, and the experience is always bad. But this one was even more profound and personal. She was close to the family during the high-risk pregnancy. She recently became a mom herself. Yeah.
Dan, I'm sorry to interrupt you. Your slides aren't moving.
Really? I'm glad you told me. Let me see what I can do here. It's still on the first slide?
Yep, you're still on your title slide.
All right, let's see what we can do here. All right, let's see here. All right, so let's try it. Now I can't get it to go.
That looks better.
Yeah, again, I'm presenting it in a window now as opposed to sharing my full screen. Thank you for telling me. I'm sorry I got about 10 minutes into this without this, although I think a lot of the stuff we talked about. I'm just going to go back really quickly. I'm going to show you the covers of those books, just so you can see those. I want you to, if you want to write those down, or if you have an interest in reading any of these, I do think a lot of this stuff is very fascinating. So here's the books we talk about. And I want you to see the covers in case you're in a bookstore and looking for some cheery reading. That there's extensive literature out there about this. When Breath Becomes Air, I didn't read all that long ago. It was fascinating. And then, of course, Dr. Kubler-Ross's on Death and Dying is the one that we're talking about. And we're on a slide where a doctor from Northwestern talks about how she was affected by this. You know, I don't have to tell you, you know, and I've experienced it myself, that if someone looks like someone, you know, someone has this, I worked in infant homicide. Me and my partner were the lead investigators, and the kid that was murdered had the same hair color, the same age, and the same first name. And he couldn't stop crying. This was one tough son of a gun. And that we're going to find that we get into these things and we have to deal with the humanity that comes with this. And I have long been a believer that trying to shy away from it. I think probably the most difficult thing that I've consistently done in EMS is dealing with the pain of those left behind as a police officer making a death notification or investigating a homicide. You're going out there and seeing the raw emotions when someone's found and notified. That grief, that pain and sadness is so dramatic. And the only advice that I have for people in that regard, as we do this, as we go through this presentation, is that I don't believe that if you stand in the background and watch, that you're going to be able to process this. And certainly not as well if you do what I have tried to do in this time, to be able to be involved. Why don't we get involved at times like this when we walk out of the living room and the whole family sitting around the kitchen looking at you, waiting to tell you that grandpa or grandma or the child is alive when you've been working this code, and the anticipation in their eyes doesn't meet the reality they're about to tell them. Or if you're there and somebody's crying and you don't know what to do, you can't just let all that bounce off you. It doesn't bounce. It absorbs, no matter how tough you think you are. So to that end, I think leaning into it is really important, in that when we do this, we at least mentally process it. And by mentally processing it, I think we do better than if we try and let it bounce off and then ignore it when it's still there. We'll talk about exactly how to do that in a little bit. But responses to death are personal and they're difficult. They depend on our personal experiences with death, things that we've seen throughout our life, ways it's been handled. Some of this involves our religious beliefs and expectations, and other things, our fears and phobias and acceptance and denial, that when we respond to a situation, whether it be personal or whether it be professional, these things are all there and part of us, and determine how we ultimately deal with a very challenging situation. And this, in fact, is a really challenging situation. I'm missing a little sip here of, well, it's not bourbon, but I want it to be. In EMS, the stages of death and dying have become fodder for test questions rather than meaningful dialogue about a vitally important topic. Not so much about, well, the person who is just hoping he can stay alive until he makes his daughter's wedding. Well, he's going to say, well, God, if I can do this, okay, that's bargaining. And that's great. That helps us identify things. I think Dr. Kubler-Ross broke this down, I think makes it a little bit more understandable. And we don't always teach these things: denial, anger, bargaining, depression, and acceptance. These stages affect a lot of things. including the National Registry exam. We can go through denial, anger, bargaining, depression, and acceptance over the National Registry. Denial, that exam isn't like that. It's not really. I had a 91 average in class. It's not right. It's not true. And then it goes right into anger. This is BS. What do we have to learn how to take their tests? Bargaining. I talk to some people I know. So we can see how we look at denial, anger, bargaining, depression, acceptance. That can happen when we lose a job. And we'll break these down with some of what Dr. Kubler-Ross says. But much of a person's actions in the face of death are based on their personal feelings and experience. And like I said, everything from religion and, the kid who was kept out of the room and couldn't see grandma when she was dead, and the people who were sheltered from this and protected and they didn't get to say goodbye, or people that got into, do CPR and not have it succeed. And these things come and are a part of us and what we do. Now, what's interesting at this conference, and I put this in here because now we even grieve on social media. So I was on Facebook and I saw this. Today, heaven got one of the most beautiful angels. I'm going to miss my mom more than anything in the world. She became my very best friend, knew all my secrets. Tonight, all I wanted was to call her and she could make it better. I wasn't ready to say goodbye, but mom was tired and she fought hard. You'll be missed at everyone that knew you. I love you, mom. Now, I can't guarantee that Meta and Facebook are read in heaven. I certainly hope so. But we communicate and we share and we grieve socially now. And I think it's important that what's even more interesting is I was doing this presentation and the woman who wrote this was in the audience. Now, I don't say anything negative about this. I think it's fascinating. I think it's a great example of how we socially grieve. And she came up afterwards and says, would you get that on Facebook? And I think that might be mine. I said, well, I was at this conference a couple of years ago and we talked and you friended me. It's like, yeah, that was when my mom died, right after that conference. And, this is, you really can't get on Facebook without somebody making an announcement about their pet crossing the Rainbow Bridge or doing this. I think that it's important that we realize how people do this and how people share. So getting back to denial, we can look at denial and we've seen death as EMS providers a lot of our life. So in doing this, we have denial and we say, oh, it's kind of dumb that you deny it. I mean, really, how can you deny it? You're dying. Well, the fact is when you first hear the news, denial gives them the ability to go on with life a little bit without that feeling. After unexpected, shocking news, you can mobilize other less radical defenses. You can collect yourself. You can think about it for a while. You've got to live for a little bit, hopefully not just give up and throw in the towel. Denial is a little bit of a mechanism that helps us transition from when we get the news to more definitive steps after getting the news of a terminal diagnosis, whether that be for us or someone else. And then we have to take some of the anger our patients have and accept some of that because we'll help them towards that acceptance in the final hour. But a lot of times, Dr. Kubler-Ross says that many times we respond angrily to anger because of our experiences with death, because of our defenses, because of our approach to things. And in that, the way we handle this anger and the way we relate to that or anything still ultimately comes back to what we have experienced ourselves. And I'm not sure anybody has had great experiences with death. I mean, we get a hospice, and I've seen some beautiful things over time, and it can be as good as it can be. But it doesn't mean it's what we want. And that, the shorter-lived phase of bargaining, you can try and say, hey, I'll be really good, or if I do something by this date, or I promise God I'll never ask for anything more. Right, that bargaining section, a relatively short-lived phase. And in depression, there's a couple different types of depression that we think about what we have to lose now and then what we have impending. I'm never going to get to see so-and-so grow up. I'm never going to get to the wedding. I'm never going to be able to go on that retirement trip we planned. And that is a real thing. And I think perhaps one of the more insightful parts of acceptance is that, is acceptance a true stage, or is it the lack of everything else? There's tired and weakness on the part of the person, and the concept of acceptance on the part of the patient is looked at as giving up by the family, because the family and the patient are often very different places. Tired, sick. I'm getting some kind of noise on here. I think somebody needs to mute if we could do that. Not sure I can do that from here. All right, so, and everything is very variable in this, that the conflict with the family of giving up or us racing the reaper, the fact is the patient is ready and wants to die. But I always thought that was fascinating. Is acceptance really the full stage, or is it just the end when there's no more and we're tired and weak and don't want to go on? Death is ultimately a human issue, not a legal issue. And while I can't say, as someone who teaches and writes an amazing yellow EMT book, unlike Mistovich's multicolor thing that he does there, it's quite heavy. The fact is that it's pretty rare to get sued in a situation like this. When I walked in and saw the 80-something pound man in bed, I didn't say, give me that DNR right now, or I'm going to have to do CPR. First of all, as a cop, sue me, right? I don't care. But the fact is it's pretty much a textbook-driven, paranoid kind of thing where we say there's a secret family member back there that really wishes they were alive and they're going to sue you for not resuscitating. This guy's dying. Hospice is there. There's piles of morphine on the counter to relieve the pain this person's in, and they're dying. You know, it's not a pump and blow situation. He's going to die, and no amount of pumping and blowing is going to really help. I think it's important that we think about that as we go into this, that we balance protecting ourselves legally. I'm not saying that we can't protect ourselves legally, but I am saying that we are trained that death is a medical legal issue and not a human issue. And we often go with the medical legal first, and I just don't think that's right. I really don't think that's the best way for us to go through and do this. So, and I know that's not popular with a lot of rule followers and other people out there. I'm clearly not one of the rule followers, but I do want to say that in this, we do need to remember that we have this balance of the legal side, relatively small but present issue, and the human issues that we have. One of those human issues, one of those things that we find is that we do need to know how to do death notifications. We are always told in EMP class and paramedic class, that's a police thing. But that's before we could call codes on scene. And as we look at this, when we do these types of things, it's realistic for us to call the code and then walk out and have a family member there. Now, current theory says with kids and even adults, people generally do better accepting the death and grieving if they're present for the resuscitation. And I do think that keeping a family present, if it's appropriate and there's space to do that, I don't see any reason why we can't. We get them out afraid that we're going to hurt them. I think part of it's afraid they're going to see some cluster that's going on, because codes aren't always the smoothest thing in the world. Well, let's talk about what happens when you walk out of that room and you go to the family in the kitchen and what you say. In a very old thing, you can tell by the font here, Mothers Against Drunk Driving, breaking bad news with concern for the professional and compassion for the survivor. The people left behind are called survivors. And I think as we do this, there's a few rules that we're going to talk about, a few considerations that I want you to think about as we go forward. all right, that survivors do need to vent. They need calm, reassuring authority that when you tell them the person has died, they need to believe that you have the authority to say it and that you're right. They need to have some sense of restoration of control because the rug has been pulled out from under them. And they need some sense of the ability to prepare and predict. And we'll talk about how to do that. Now, just to give a whole part whole kind of concept, right before I left Maine to come down here to Texas, I was sent to a call from a man found hanging in the woods. And it was a young man, a 19-year-old. And he had walked out the back of his house. He had kind of a hunting tree stand kind of thing. I went up there and hung himself. I think he probably took a little bit of a distance, broke his neck. I think it was pretty instantaneous. But he was 19. Of course, it was Maine. It was a little chilly. So in doing this, we found where he lived, but no one was home. So they left. They said to me, I worked part-time. I was full-time a lot of my life as a cop. And they said, Dan, you can go. And I'm thinking to myself, man, here's this kid on the job, 6 months, going to have to tell his family. He doesn't know what he's in for. So I stuck around. The father came home and he screamed and cried and fell to the ground. And that calm, reassuring authority is a little bit of an anchor for people. Sometimes everybody said, now I'm not saying I was cop authority. I'm like, this is what we're going to do. That gets people back in a spot where you can give them control. And that control means, well, I have to get a hold of my wife. And what does this mean for me? I've got to try and put all this stuff in order. And then preparation and predictions, like, well, what does this mean tomorrow and the next day? So whenever you do a death notification and you talk to somebody, you always write down everything you tell them. Because if you stop back, and I stop back to see families when I can, when I stop back to see them, they often have that paper in their hand or in their pocket. Right? The coroner's been involved. It's their case. Here's their phone number. Okay, and you put down the name. You don't talk about the body. This is their son. You can say your son. You can say Eddie has been taken to this funeral home. I won't be able to get in to see him now because it's closed, but the coroner will work on this tomorrow morning, and you'll be able to do that. Think about being told your son is dead when in fact you can't even see him to verify it. And then here's the steps that are going to happen as you go forward. And those are the things that, in the big picture, how these 4 bullet points play out. You're going to want to call your family, have people around. The funeral home will talk to you about setting a date and all these different things. But right now, here's what we're going to do. So survivors experience denial, shock, and numbness, and that decreases their memory. That's why you make that list. The fear and powerlessness makes people feel vulnerable. They just don't know what to do. And then we tend to overprotect people. You don't need to do that right now. Let somebody do that for you. No, you're not going to do that. In fact, give people choices. Choices mean strength. Now, at another conference I was at, a woman came up to me after I did my suicide presentation, and she said, you talk about seeing the body and what to do. And I heard the call go out over the radio. My husband and I were both on the rescue squad. And they said there was a man with a gunshot wound they thought was self-inflicted in the canyon. So I got in the car and I went because I knew it was my husband. I got there and had him covered with a blanket, and I knew everybody there, and they came and they held me back, and I was trying to get to see him. And finally I fought and I fought and I fought. And I got to see him, and he had shot himself in the head. And I looked at him, and then they covered him up, and then I was better. Because I never would have believed that it was him under that blanket unless I got some closure. And while he shot himself in the head, she said, the fantasy of what they're trying to protect me from might be worse than the reality I would see and the benefit that it would give me. Now, I'm not saying everyone should be in a spot to do that. We have crime scene considerations and other things. But the truth is that these were words that were spoken to me, that the fantasy can be worse than the reality of what they actually see when they see that deceased loved one. All right. All right. From that Drunks Against Men, Mothers Against Drunk Drivers, sorry. Permission was finally granted for me to see Timothy on the condition that I didn't do anything silly. As I watched, I presumed that meant I couldn't touch him or disturb anyone. Timothy was my child. He hadn't ceased to be my child. He was dead. I needed to hold him, to look at him, to see his wounds. These instincts don't die when the child dies. I needed to comfort and cuddle, examine and inspect, to understand, and most of all, hold him. But I had been told not to do anything silly. And the fact is we may have been in scenes, a young man shot himself in the head. I was the first cop there, and the mother is sitting there, holding his head in her lap, sitting in a big puddle of clotted blood with his eyeball extruded, just rocking and holding him. Now, she ended up going to the hospital, the acute stress reaction. The ambulance had to take her. And you don't know what a person's individual response is going to be. But the truth is what we believe is best for people may not be what's best for people. So I think that to a great extent, it's very, very important for us to be able to look at this from that human component that I talked about. And when I do these presentations, I know that this isn't the medication that involves defibrillation and involves great medications and adenosine and SVT and trauma and things like that. But this is important stuff. You know, this is going to be how you make a difference in someone's life. Even though the patient's dead, you will make a difference in the family and the people left behind. Usually when you leave those scenes, they have no recollection of what you say, but they remember your face and a kindness that go together. And that's very important. So be absolutely sure of the identity of the victim, of the patient that's deceased, because if it's wrong, you'll get to be in quite a jam. Don't use the radio, use your mobile or MDT to get information out of somebody who has to be notified, especially in small communities. Consider the health of the survivor. Somebody's elderly husband died, or elderly wife died, and the man is a train wreck with minimal left ventricular function and cholesterol and hypertension and diabetes. I think you have to look at things a little more differently and slowly and get support there, and always done in person. It's really important that we notify the survivors in person. And as I said, I've done many more of these than I would like to have ever done. Work in pairs. The concept of working in a pair gives you time to take a breath and let someone else talk. If you do this all yourself, and I did when I had that new kid, I showed him the whole thing so he would know how to do it. But I was burned. I was just white for a couple of days. The other thing is if you get in and end up saying something that really annoys somebody, the other person can jump in and take over. Simple and direct statements are the best. He's gone to heaven. He's not with us any longer. He's gone to someplace better. That could be the trauma center. We need to use simple and direct statements. Hi, my name is Dan. I'm from the ambulance. Despite having everything possible done that we could do, I'm sorry to tell you that, insert person's name, that John died. He is dead. And that's not cruel. Code is cruel. Saying things with code is bad. And then anytime you talk about it. So does John's doctor recognize that was this death expected at all? Had John seen his doctor recently? will the funeral home come for the body? No, will the funeral home come for John or your dad? We can't take the humanity out of this. And a lot of people are hesitant to express condolences because you feel they're lame. But the fact that you offer a condolence is still human. Excuse me. Inappropriate. So it's okay to say, I am very sorry for your loss. All right. Now, there are things you can say that aren't good, or things that you can do that aren't good. Like, I know how you feel. Yeah, no. Even if you've had somebody die that looked the same relationship, same amount of love, everybody handles things differently. Time heals, and there's things you can say that, oh, they sound really amazing, but the truth is they do come off lame. I'm so sorry for your loss. Now we'll say, okay, now here's what we're going to do. We have to call, since this didn't happen in the hospital, there has to be a report. The medical examiner is going to be involved. We're going to be here for a little bit longer. This is what's going to happen. That's what you roll into, not this stuff. Don't use disempowering terms. Remember, choice makes a difference, right? Don't you think you don't need that right now? Listen, little lady, let me take care of things right now. That's not it. That's not it. Someone needs to be strong. They look back that they dealt with it, that they weren't being taken care of, that they can process and handle things. And now don't say to the little kid, oh, yeah, your father's dead. You got to be the man of the house now, because that's not appropriate. He may or may not have to be the man of the house. And if he's 7 or 9 or 12, it really is putting quite a trip on this poor kid to be able to do that. So the concept of avoiding unhealthy expectations, we want to solve things. We want to say something. We want to do it with meaning. And sometimes words do that, and sometimes actions do that. And that's important. Avoid cliches and judgments, oh, they're in a better place, or, yeah, the place they want them to be in is still lying in bed alive in that bedroom where they last saw them. And death isn't always symmetrical. One of my most interesting cases, I was investigating stuff, I was a street cop, and it was unattended death. And I get up there, EMS says, yeah, he's been down too long. Camera says, okay. I was talking to the family, and I said, well, so tell me what happened. And the EMS just kind of said, let's back everybody out. Let's see what we got. And he had cancer, and they had bought a new tympanic thermometer. And the hospital said, he's on chemo. Make sure he doesn't get an infection. Okay. Bought this thermometer, and they put the batteries in, and they put it in his ear, and it read error 5, E5. Like, huh. How they did a few maintenance wraps, and they changed the batteries, and they did it again, still said E5. The guy said, I'm kind of tired. I need to go to bed. I'm just really tired. So they tried it one more time, same error. Like, all right, you go to bed. We'll work on this. When you get up, we'll figure it out. So he goes to bed and dies. E5 was temperature not in the human range. He was in the process of dying while he was sitting there. His body was shutting down, giving up on body temperature. He was sitting there physically dying. And when he said he was tired because he was dying, literally dying at that moment. So the family and I look at what E5 is. It's like out of the normal human range. I'm like, wow, he was sitting there dying as they talked to him. Don't tell children before parents. They won't have any support without that. The parents have to get the information, get it together, and maybe it's for them to tell the children unless they want you to. And write down things they'll want to know but won't remember. Do it in detail and plan on spending some time. These are key elements of death notification. Now I'm going to take a breath for a second. I'm in a spot where I can't necessarily see the screen. I don't know if there's a chat or anything like that, if anything's going on. I would love to know if there's any questions. Everyone looks like they're signing in there. But are there any questions? Lost audio, now back. Are there any questions I can answer before I go back and do one more section on this?
Quiet group tonight.
Well, you know, this presentation really is a real pick-me-up. I'll give you that. But it's important, believe it or not. And I'd like to, you know, continue on and do this. Hopefully, we'll keep everybody there because I do believe that it's important stuff. So the concept of resilience is a very big topic in EMS today. So how do we prevent stress? And ultimately, in the same breath, we want to promote resilience. We can prevent the stress. I can deal with stressful situations. What can I do every day that's going to help me get by and not have long-term effects from stress? You know, the concept of a sense of humor, I think, is good. I love The Onion because but that brings me into gallows humor. The concept of gallows humor is when we laugh at something that's inappropriate for people generally to laugh at, but we find humor in it because we have seen things and we look at things differently. We take death or dying or tragedy and put a humorous spin. And some people say that that's the mechanism for us for dealing with sadness, for our mechanism for taking difficult times and putting some humor in and processing them. And I think that there's something to that, but I'll actually go one step farther. As we do this, I actually believe that it's actually being a part of an elite group that we feel so comfortable in that we can make such outrageous comments without fear of reproach. We're part of an elite club. And that when we do something and you sit there and get back from the ambulance, everybody's got a little bit of sadness hanging over, but there's always one person that finds some hilarious, smart-ass thing to say that breaks everything up, and all of a sudden we're together again. And I believe that the joke is good, but I believe that the together is important as well. You'll see later that people who have a support system generally do better with stress than people who don't. All right, so I have a video, but I think with the quality, I'm not going to show that. So when we talk about resilience, let's talk about how people who have had difficult situations, traumatic incidents, what factors help them survive. Patients who experienced a traumatic incident but reported less stress in the aftermath had a few things in common. The first was social support. The belief of persons being cared for, that they're not alone, that they're part of a team or system, has a significant benefit in the reduction of post-traumatic stress. And that's where I think the gallows humor comes from, that it puts us in a situation where we're together. The humor isn't the cure, the humor is the vehicle. And the group is the cure, the support that we have from people that have gone through a similar thing. That is where the power is, I believe, in gallows humor. And secondly, a person can manage their own problems, self-efficacy. People feel less helpless and more in control. They'll have less long-term stress as a result of the incident. I'm going to talk about a theory that's out there, not my theory, but I do want to talk about it so we're clear in what we're talking about. The filing system of the brain has the ability to function more normally. So let's say that we have, I don't think the way I have this is going to let me draw, but let's say that normally in our day, at the top we have alarm, and at the bottom we have withdrawal. But in this situation, we avoid alarm and withdrawal in most events of our life. We can have our car break down. We can have a fight with a spouse. We can have a problem at work. We can have outstanding events in the birth of a child, and we can have a wide range of emotions. But if we keep it between the top and the bottom line, our brain is able to file things appropriately. Even in the face of some pretty traumatic things, if we can keep it between these lines and not go out of the top, alarm or panic or rage, or the bottom, withdrawal, our brain says, okay, we saw a bad thing here, but I think I got a handle on this. I'm going to put it here. And then you're okay, or at least largely okay. But when that file sits out there open for all that time, it's believed that's where post-traumatic stress comes from, when the brain doesn't process. Now, this is oversimplified. I don't know the background of everyone here, but if you're a social worker, other things, you'll say, well, okay, that's that's good. But in the grand scheme of things, what can we do to keep people between these lines and keep the filing system working during a very traumatic time? And LaGuardia Community College and the Resiliency Consortium of New York City came up with a plan they called SCAP, that providing social support, choices, being able to anticipate, and then plan and organize. SCAP are the foundations of keeping people between those lines. And we've talked leading up to this about how and what that means. So to this end, they then added E for every person and at the bottom every time. Because I don't care if you are dealing with someone who you've just told that a child has died, or if you're dealing with a partner who just made a fatal medication error, or just had to go do a death note notification, walk out of the room and say that the child or the parent had died. That when we're dealing with both our provider, our person that we go back to the station with, or dealing with that family, these concepts are the same things that help anybody in any situation process stress better, more resiliently. So let's break down the S, C, A, and P. That social support, isolation is your enemy in this case. Tell the patient, tell your partner, tell whoever it is, the remaining family, we tried, we couldn't do it, but I'm here for you right now. Some important things I have to tell you. I'm going to let you know what's going on, but you aren't alone. And I'd like to get somebody here to be with you, so you continue not to be alone. But until that point, I'm going to be here with you. And that calm, clear, compassionate voice that's there is going to be like a beacon to a person. And that this beginning of that social support, they know that you're going to be there with them, that you're a reliable and trustworthy person, and that you're going to just not abandon them in the middle of this horrible, tragic mess. Now, choice and control helps us provide hope and structure. Even simple choices provide a sense of control. Which arm to place a blood pressure cuff on, arranging family to go to the hospital and how they're going to get there. Whatever it is, giving somebody choice takes their mind off dying, takes the mind off their condition, and gives them some control. Do you want me to leave the key to your house where I found it, or do you want me to give it to your neighbor? Do you want to? And a few things. Now, obviously, critical patients, you can't do all this every time, right? Sometimes you have to be faster. If you're working a code or something, and there's a limited number of people, I know you can't always do this, but the simple concept of giving choice or control. Let's say that you got a person had a really, really bad call, and you're coming on the next shift, and you see this person is a wreck. Think about the choices that you can give them. Hey, listen, I want to sit down and talk to you for a second. Do you want to do it here, or do you want to go find a place outside? Do you want to get some air, or do you want to stay inside? Find things that just make them have to think. I was on a call one day, and a woman clocked a guy on a bicycle. He's a heroin addict and probably was stoned anyways when he got clocked. And when you're that loose, you don't get all that badly hurt. He bled a lot, but he was fine. So you've been in EMS for it. He bled a lot, but he was fine. And I didn't recognize it was a friend of mine's wife. he came up and I said, Steve, she's taking this really hard. There are a few things I want you to do. I told him about not being alone and choice and control and things that we're going to get into next. But the concept of giving choices is giving somebody some power and some control. And if it's something that doesn't cost you anything, let them do this and engage their brain to get farther. And then anticipate. Anxiety is caused by when you don't know what's going to happen next or how it's going to go. Explain it. The patient should never wonder. Your father is in the bedroom, he's on the floor, and we have some tubes and some things that are in him still. But we've talked to the doctor at the hospital. We believe that we've done everything that we can, and we're not going to work anymore. Like I explained to you, he's died. Now, he will be there for a little while on the floor, okay? And we're going to do that. The police are going to take a report, and the medical examiner is going to come, and they're going to take your father. Or if we can get the doctor to sign the death certificate and say this isn't unexpected, we can have the funeral home come and take care of things. Now, they'll tell you what their procedure is, but they're good people, the local funeral home, I know. So go on and let them know what the steps are. Now, they're not going to even remember you talking. That's why we write it down. But if they know the things that are going to happen, things change, then finally we plan and organize. In doing this, we prevent feelings of bewilderment and loss. We continue to plan and organize. The patient's able to take some steps. Yeah, maybe I do need to call a couple people now. Help lock the house, secure a pet, get a neighbor. Say the police are there, we're going to get your house. So the police drive by it and take care of things. Those phone calls, notifications, that this whole concept of SCAP, I'm just going to zip back here really quickly, that this is the way that you deal with people that are survivors if someone died. It's the way you deal with a partner who's had any traumatic incident, a death of a patient, medication error, and they think they killed somebody, a profound bad call or went to you know what, and they're struggling with it. These are things that you can do to help them in that regard. So social support, choice and control, anticipate what happens next, and continue that anticipation by helping the patient plan and organized. So, I think that when you go through and, we do this, I don't know what time I have here. I'm kind of winding down in this. I got a couple slides left. I certainly can have time for some questions for y'all, but let's come full circle. Remember I said that I don't believe that you can successfully stand against the wall and have grief and sadness bounce off you. I think one of the best antidotes for us is even acknowledging that we're not going to say the perfect thing every time. I think we have to acknowledge that there is no perfect thing every time. Leave knowing you've done something positive for those left behind. When you leave, if you can say, at least I did this, it's different than standing there and watching the whole time and not doing anything, or not taking a risk or making an action. Even when your brain or your heart or your gut said to do something, it's important that you do those things, because that's how you survive. That's how you deal with it. And leave knowing you've done something positive for the deceased. Because they're not there. You tried to resuscitate them. Could have been a medical code, a trauma code, whatever it is you're doing. And you find out that there's certain things you can do involving the family and connecting them, or anything that happens at the end, doing something even for the deceased. Live your life from this point on with realistic beliefs about life and death. I know this is one of the soft topics. Hope you've had lots of juicy medical and trauma things in here. But the truth is that we're called upon to do this more than we think, or even support people more than we think. And if we don't know what to say or what to do, I hope I'm able to help you figure out what that is. Something well-intentioned is better than nothing said because that you're afraid of saying something wrong. or doing something wrong. And so much of this, again, comes back to our beliefs about life and death, our experiences, and how we'll interact with people that are left behind by death. So it wasn't all long ago I got my AARP card. Maybe that's what made me do this. Maybe that's what made me do this presentation. But my name is Dan Limmer, and I am here to answer any questions or to do this. Like I said, it's not the clinical topic, and I get that, and that's okay. I can deal with that. But do we have anything else that anyone is saying I can do?
Dan, this is Matt.
Hi, Matt.
The process here in Trumbull County has changed a little bit, and I'm sure it's a little bit different across the state. Not everybody here is not from Trumbull County, and I understand that. But our corner has instituted a few changes so that these guys have more of a protocol, more of a guideline. It doesn't have anything to do with talking and all that. That I think that's kind of just a gained skill. I mean, I appreciate the tips and everything, but it's a skill that you just have to gain after a while. I think working in this business and dealing with the dead and the dying and the survivors around us. I worked for a private company early on in my career that was notorious for doing every removal that we could find. And so we got schooled pretty well in how to handle that and how to be professional. And I think people need to realize that, when you're handling that body, you're handling somebody's loved one and everything. And, you have to do that utmost respect and keep the cot nice and neat and all those good things. And I think that has an impact. It just so happens that today's the anniversary of my father's death. He passed away about 6 years ago, and he was very ill towards the end of his life, and we dealt with hospice and everything else. And I didn't know the ambulance crew that finally came and took my father away, but they were really good at it. And that sounds bizarre, but they were really good at it. They were very respectful and very real tight with the sheets and make it look nice and neat and clean and professional and respectful. And you give the deceased a pillow and all those good things. And it made a difference. It made a real impression on my family. They had never seen anything like that before. But I mean, obviously I have, but it makes a real impression. It's good that you're putting a focus on that so that, these people are already having a bad enough day if you're there to take their loved one away. You want to make sure that you're not part of their story 20 years from now. Hey, remember that a-hole paramedic? You just don't want to be part of their story that way.
I think a lot of people are afraid of being that paramedic because they don't know what to do. And I think one thing you said at the very beginning, Matt, was that, people don't know what to do. And I don't know if this is an innate skill or not. I think there's some people that are probably more outgoing and more people-like than others. And I think that nobody really, without any training or any ability to do this, knows what to say. But the benefit of saying something, it doesn't just affect the family. It affects the EMT or the paramedic as well, because they had some sense of being able to do something rather than walking out and saying, I can't believe I couldn't even say I'm sorry. I was like frozen, You really can't say anything that wrong as long as it's heartfelt. But I do agree. I don't want people to not engage in things because they're afraid. I don't think that's to do it. But I also do believe I totally agree with you. The more you see of this, the more you do. And it's not that, oh yeah, death doesn't bother me anymore. Tough guy, EMS stuff. I'm talking about having some experience, let you know, I'm going to say these 5 words, and then they're going to fall on the floor crying. You'll know what's going to happen. And that I think that to a great extent, that when I started 40-something years ago, we had to take everybody to the hospital. But the truth is, on the way to the hospital, our CPR is crappy. It's dangerous for us in the truck. And if, we're going to transport them, and 25 minutes later, when I pull them onto the hospital stretcher, they're still going to be dead. We're now at the scene and putting ourselves in a spot where we have to communicate more than ever. You know, when you had to go pick up the body, and they found someone dead, the police called, and you were moving the patient to the medical examiner. That's even a different state than when the family's sitting in the kitchen with hope that they're going to go. You know, watch all the hospital shows. Remember ER? John Carter came out one time. He says, "We're doing everything we can. He's not responding. We're going to continue trying." But I have to tell you right now that we're not optimistic. I call that the John Carter, because it's ER and not just some Chicago bullshit show. I recognize how old I am, but I've actually tried to use that myself. And if the code is going really, really well, and we're getting to the point where we're winding down, I'll stop out and say, you know, we're doing everything we can. He hasn't responded. We're going to continue to try for a bit longer, but you can actually do these things in between, or have somebody extra with the family that peeks in once in a while and lets them know what's going on. Think about how that would be for someone. You know, I think those things are big. And I know I'm a touchy-feely old fart. I get it, you know, I'm not supposed to be after all these years of copping and doing EMS, but I found satisfaction, and I found a little bit of sanity that I may have, largely because I have embraced this and leaned into it rather than trying to avoid it.
You should try to treat everybody with compassion.
I think that's a absolutely true statement. I know that we're challenged sometimes. There are people that push us. There are people that take the stress of a death and dying scene and decide to yell at us and do that. I think it's very hard for us sometimes in certain situations, and people doing things really outrageous. But that is such an important foundation. I think shows a lot about our professionalism, attitude, and again, like Dr. Kubler-Ross would say, it also has to do with us being settled enough in the situation to be able to really understand it.
Are there any other questions or comments for Dan? Roman Swearden, do you have something to say? Okay.
Yeah, I was gonna tell, one of my last actual death notices I did, it was a hospice trip. The patient was alert and oriented up in the bedroom and wanted to walk down the steps. And we didn't let him. We took him down in a stir chair. And by the time we got him to the ambulance, I could tell he wasn't going to make it. So what I did is I called the family over and let them go in the back of the ambulance for about 10 minutes with him. And he died right in the back of the ambulance in his driveway. And the family was so grateful that I just didn't pull away and just let him die by himself.
Oh man, that's a gift.
Yeah, and it's all about dignity, not for the patient, and for the family. And they were so appreciative of it and everything. I mean, it changed the whole dynamics of that dying scene.
And I think, as Matt said, I think that probably was quite an experience for you and affected the way you handle things from that point on.
Yes, it did.
And Hannah commented here. I'm in the looking at the chat. Was given 3 to 6 months to live in May of 2020. That the stages are not always linear. They do bounce back and forth. And I think, Ken, that's a really great point. And I hope you're doing okay now. 3 to 6 months in May of 2020. You're coming up on I'll knock wood here, on a couple of years, and hope that you're doing well. But I spent the first 3 months in a vicious, hellacious circle, bouncing between those stages. And I think that it couldn't be said any better. It's a really great point, Hannah. I don't know, Matt. I think we may have to get people some Red Bulls and some therapy now to get over this presentation. I'm not sure.
Hey,
Well-
Dan, so I have it on record. Who has more book sales, you or Joe Misovich? And I'm going to hold that to him.
I would never disparage Joe. I think Joe is a prince among men, and he is honestly like a brother to me. I will say, though, that I have done more books only because Joe was so dedicated to Youngstown State. Joe's done an EMT book, and we have done 1, 2, 3, 4. We've done several books together. But because I was either doing police work or not being a program director as Joe was, and then department chair for years, and then retired from police work, I have a lot more time. I've done 17 or 18 books, a few electronic products, and then started the app company. So it might be a little bit more prolific. I would never challenge Mistovich on pathophysiology. I'll let you know that. And any of you guys that have been through any of his classes know that. He's a prince among men.
Yeah,
Don't
Joe's
tell
a
him I
good
said
guy.
it, but he is. Yeah.
Did I see a hand up there? Well, if there are no more questions or comments for Dan, we'll give you guys a 5-minute break and move on to the next subject.
All right, you guys all be safe and well out there. Stay warm up there. I'm in Texas, so I got a little bit warmer gig down here, and currently it's not hurricane season, so I'm good. But you guys take really good care. I'm glad I had a chance to share this. I hope you don't ever get a chance to use it. I do hope you take a chance and go out and do something really good that might not be in your comfort zone, and that it goes well for you.
Thanks a lot, Dan. I thought that was actually a very insightful presentation. It really touched on a few things, and I think it makes a difference. Not
your average EMS one, but that's the way in my advanced years, I've decided to do the fringe topics, and I'll keep going. And thank you for the kind words, and thank you all for listening. Be safe out there.
Good night.
Take care.
All right, everybody. We're going to do about an hour and a half of geriatrics here. And this is something that is always needed for all of the refreshers that you do. It's very hard to come by. We actually just partnered up with the Ohio State Medical Center hospital down in Columbus. We're going to do some projects with them, and they're an actual level 1 geriatric certified emergency department. So moving forward, we're going to get some ideas from them to bring those to Trumbull and also to provide you with some continuing education moving forward. Today's objectives, what we're going to do is we're going to discuss a lot about the demographics of the geriatric population. The Census Bureau put out recent stats in 2020, and we're going to go over those. We're going to discuss health and healthcare. We're going to talk about some anatomical and physiological changes. We're going to talk about some medication and polypharmacy. And then finally, we're going to talk about the patient assessments and specific problems that these geriatric patients have. Overall, since 1900, the life expectancy has increased about 43% for all ages. And in 1900, it was about 50 years of life. 1988, it rose to 75. And in 2019, it was 78.8. But when we go to 2021, the life expectancy dropped about 1.8 years. Does anybody know why?
The cooties called COVID.
That's exactly right. Yeah, so COVID actually dropped the life expectancy globally and also in the United States. And in 2021, the life expectancy was 77 years. People greater than 65 years old are the fastest growing group in the United States. In 1900, because of the low life expectancy, they were only about 4% of the population. But in 2019, they accounted for 16% of the population. It's estimated by 2040 that there'll be about 22%, or almost one-fourth of the population. And interesting enough, and I think we can all relate to this, that about half of our EMS volume is greater than 65 years of age. When we talk about the Census Bureau statistics, about 73% of men actually live with a partner or spouse. And compare that to about 50% of women living with a partner or spouse. And that's because women tend to outlive men, and you'll see that. Only 20% of men live alone versus 33% of women. And, the 7 and 13% respectively talk about other institutionalized living arrangements. Over 50% of the people 65 years and older live in 9 states. And I want to talk to you, look at Ohio and Pennsylvania. But mostly, they talk about snowbirds and, Dan Limmer got out of the snow and he went down to Texas. But California has the most, followed by Florida. Then we go to Texas, New York, Pennsylvania, and Ohio actually has about 2 million residents being over the age of 65. Illinois, Michigan, and North Carolina are those other states that comprise of most of the people greater than 65 years of age. When we talk about the last 10 years and where people actually migrated to, you can see they migrated a little bit to the Midwest. Most of them went out west, and then some of them went out down south. But, overall, they're really distributed, and they're not anywhere specifically where they're located. But the Midwest has a big population, and that's why those 9 states have the most geriatric population greater than 65 years old. Over 65 is a total population. I want you to look at West Virginia. It seems like West Virginia and Florida have about 1/4 of their population being elderly. And when I lived in Florida, they actually had planned communities, and they specific. Anyways, one of the coastal. One I can't remember it here, but Palm Coast. That's what it was. Palm Coast was actually a retirement community that was planned for those who had to meet a specific age requirement. And the community grew so big that they actually had to take over other land, and now it's actually severely congested. And they didn't plan well for that. Because as the population aged, a lot of the younger population came in, and it wasn't meant to be like that. But you can see that you've got Maine, West Virginia, and Florida accounting for 1/4 of their population being older than 65 years old. When we talk about the family household incomes, and that's with head of household being greater than 65 years old in 2019, 47% of them made over $75,000 or had $75,000 for their annual family income. So they're not doing too bad here, right? Most of that has to come from either retirements or the population's actually working longer. My dad, when General Motors shut down in Lordstown 2 years ago, my dad wasn't ready to retire, and he was not even at 65 years of age, so he couldn't retire. So he actually had to go over to St. Louis, Missouri, and he had to take a job out there. So he went out there for about a year and a half until he actually came to the retirement age, and he retired and came back to Ohio. But even though, 49% of people make over $75,000, there's still some concern about those living in poverty. So the lowest group living in poverty is white, and the highest group of living in poverty is African American. And interestingly enough, about 1 in 10 people over the age of 65 live below poverty in 2019. The rates of employment from 2000 to 2020, from 2000 to 2020, actually has consistently increased. What you see here, they've consistently increased to the year 2020, and that's because of COVID. You see these sharp declines here. Both men and women, they exited the workforce. And when you look about research studies as to why we're in the predicament that we're at, is a lot of these baby boomers decided that now is the time to retire. You look at other industries too. Who were the experts? Just look at the fire service. Who were the chiefs for the long time when this came around? They got us through the pandemic, and then they decided, well, now's a good time to retire. When it comes to education, the overall total population has at least completed high school, and about only 1/3 of the elderly population greater than 65 years old actually have a bachelor's degree or higher. And that's because, what it was people would move to different parts of the country or different parts of the world. They would actually go ahead and they would find a job, and the guys would go to work, and the wives would take care of the kids and get everything ready. And that's actually how my grandparents met. They moved to McDonald, Ohio, and they met in the steel mill. And both of my grandfathers worked, and both of my grandmothers did not work. And so the guys were responsible for going to work and providing the income, while and both my grandparents had big families. But overall, most of them were high school educated at least. The demographics is white tend to typically be higher educated, completing high school, than African American or Asian, and that's total population over 65 years old. But as the years went on, between 1970 and 2020, the percentage of older people actually completing high school rose, actually, from 28% to 89%. The household net worth by age, anybody less than, this is interesting, I left all the ages up here, but those less than 35, the median net worth is about 13.9, with the average net worth being 76,000. And then when you look at the age 75 and up, the median net worth of somebody who's in their 70s is about $250,000, and the net worth is near $1 million. And sometimes that has to do with their assets. So a lot of these, these people, they've started mom and pop shops, businesses, they've been bought out, or they acquired a bunch of land and apartment buildings. They've had bonds, and they've invested early in the stock market. But they do have a good net worth. It's just a matter of, where is that distributed? Is it distributed in land? Or is it actual cash where they can liquidate that and live off of? When we talk about health insurance for the population older than 65, most of the elderly is covered by health insurance, about 99% of them. 52% of them are private insurance, with 94% being about Medicare. So in order to get Medicare, you have to be 65 years of age, and they're actually looking to increase that. So that's important when we start talking about ambulance statistics, because, let's face it, even though EMS is a service, they're still worried about reimbursements and offsetting that cost. So the American Ambulance Association actually has a spreadsheet that I downloaded just the other day looking at this, and they have 3 tiers for actually EMS billing. So let's just say, an ALS trip is about 250 to maybe 300 base, and that actually depends if you're in a rural setting, an urban, or an urban dense setting. And then they allot you to have $8 per mile. So that's Medicare. So we know that, we should expect a certain amount of reimbursement from the Medicare population. And with Medicaid, it's even less. And with private insurance, it varies based on the in-network and out-of-network providers. But the good news is that most of these people are covered by some sort of health insurance. And the healthcare marketplace actually made it better for people who maybe had to have early retirement, didn't meet that 65 years of age requirement to get full Medicare. They actually had to go on, and were able to rather go on to the healthcare marketplace, or otherwise known as Obamacare, and get insurance to help them move forward. A big thing in the local areas is the Delphi retirees. Some of those guys, they took the buyout and then they lost their health insurance several years down the road. So that's where state assistance come in, and that's where the healthcare marketplace exchange worked really well for them. But in 2019, about 22% of people between the age of 65 and 74 rated their health as fair or poor, and that actually increased to 29% for those who are about 75 years of age or older. And interesting fact that most older Americans have at least one chronic condition, and many have multiple conditions. And we'll see that here throughout the rest of the lecture. Chronic conditions for people older than 65, majority of them is going to be arthritis. They're going to have some coronary heart disease. About 9% of the population in that age group has about an MI. 4% get chest pain. 1 in 4 people actually are diagnosed with cancer with the age greater than 65. 10% have COPD. There are obviously strokes are big here, and then diabetes. We didn't have, dietary restrictions. We didn't really know a lot about nutritional facts until of the recent decades. And so, they learned how to cook, and they used, ingredients such as lard, and they raise their own food in livestock. And that's where some of this cholesterol, diabetes, and coronary heart disease comes from. COPD, the baby boomers were right there in the midst of it, where the ad campaigns got really inflated for having cigarettes and Winston-Salem and Marlboros, and they made a whole lot of money off of that. And they didn't really know the adverse effects of smoking until now, with all the research, there's bulletins everywhere saying that, if you smoke, you could ruin the fetus, you can have a miscarriage, you'll have, 10% lesser life expectancy. So that's why we typically have these chronic conditions in the elderly population. There wasn't a lot of education. There wasn't a lot of public outreach. They just did what they knew, and they did what they thought was in their best interest. 13% of people reported taking prescription medications for feelings of being worried or nervousness or anxiety. And actually 12% of the elderly population reported taking prescription medication for depression. And as their spouse or as their family or their kids, go away, or as their loved ones pass away, they start to have feeling of loneliness, and that's why you have a bunch of senior levies that are on the ballot, where, you can grab a bunch of, seniors, bring them together in a community center, and they can have friends, and they can do activities, and they can have social hour. But we definitely don't want to abandon our elders as they get older, and as we get older as well. In 2019, they did a study here, and they wanted to see who actually of the elderly population had any sort of difficulties with anything. So you can see that almost in every category, the elderly population had some sort of disability. But the most common disability they had was difficulty with mobility. And as we go on and we talk about the musculoskeletal changes, you'll know that you'll find out that the trabeculae and the vertebrae actually widen. You don't have this solid bone anymore. You start to have osteoarthritis, osteoporosis. The cartilage stiffens. You can't really get that knee to move very well. And then the other highest one is difficulty hearing. So there's a lot of difficulties that they encounter, but physical functioning and difficulty with mobility seems to be number one. During COVID, they actually did a study, and they wanted to see what population had the most anxiety or depression over a 7-day average from, this is April 23rd, 2020 to March 29th, 2021. And interestingly enough, the blue lines on the bottom only about 20% of those who were 80 and above and between the ages 70 to 80, let's say that, only 20% of that population actually had fears or symptoms of anxiety and depression. If you look on top, you'll see the dark blue line, and that dark blue line represents the age group 18 to 29 years old. And that shows that almost 60, right around 55% of the population, right at the peak of COVID, got symptoms of anxiety or depression. And, you know, when you research a little bit more as to why this happens, is why did the elderly population not get the anxiety or depression versus the younger generation? And that's because the elderly have been through wars. They've been through other things that have caused, you know, some hardships. They went through the Great Depression. They went through economic hardships. So they know and they usually believe that things will get better. And this graph is a great indication that, you know, they did not feel that way, whereas the younger generation did. When you talk about COVID-19 and the well-being of people, you know, about 21% of Medicare beneficiaries, and just to clarify, to be eligible for Medicare, you have to be 65 years of age. So 21% of Medicare beneficiaries reported that they were lonely or sad, more so in women versus men. 15% of Medicare beneficiaries reported feeling less financially secure, and that's because you had businesses closing, you had the, you know, worry with the stock market. You just weren't able to, you know, you didn't know if you owned a store, if people were actually going to come and shop or when they were able to come back in. And again, that was more women over men. And then you had 38% of Medicare beneficiaries reporting less socially connected to families or friends. With us and everyone on this call today, we can connect with everybody else. And we had somebody in Hawaii, we had them in Mexico, you know, Dan's down in Texas. And that's because of technology. We can access readily and it's readily available. We're familiar with things like iPhones and Androids and computers, whereas the elderly population is not. You know, and that's why sometimes, you know, go online and do this, you know, it's not that easy for them. And during daytime television, when we're all at work and they're in front of the TV watching The Price is Right, you have a lot of ad campaigns talking with phone numbers and to call this phone number. And that's because they don't know how to access the technology. The CDC put a report out from 2014 to 2017, the arrival by ambulance to the ER, and I think we all can relate here. You know, those who are greater than 65 account for about 20% of all ER visits and 36% of all hospitalizations. You know, this graph here on the axis is the percent of ED visits, and on the bottom is the age group. And so 53% of ED visits for 90 years or older happened between 2014 and 2017. When you look at the 70 to 79 age group, you got about 30%, and it continues to go up as you get older. And the reason is because the mobility is down. They can't see well. They can't hear well. They're more, they don't want to lose their independence. They try to do a lot of things on their own. And sometimes they can be stubborn and not ask for help. You know, but that's the reason why they keep going to the hospital. And they tend to kind of like think that some of their symptoms or their pains are just related to old age, and not that it's a sign that they need to go to the doctor or to the ER to figure out what's wrong. And by the time they do make that attempt to go to the ER, oftentimes it's too late, and that diagnosis is often far more worse than what it could have been if they would have went earlier. Now we're going to talk about some anatomical and physical changes that happen in the body, and then we're going to go into some specific problems that happen. Some of this might be repetitive, what you're going to hear now versus the end of the lecture, but I think it ties nicely together. Every body system that you can think of changes as we get older. All right, from the central nervous system and the decrease in the synapses, to changes in cognition, to the cardiovascular system where we actually have calcification of the aorta. It's not able to expand. We have decreased maximal heart rates. We have increased hypertension. The renal clearance, our kidneys don't function that well, so we're not able to eliminate drugs that might be not so harmful to us, like an NSAID or ibuprofen, right? But you give it to somebody who has decreased renal function, and now it becomes toxic to them. And then digestive system, they have changes in appetite and weight loss. So we're going to go through a couple of these as we move on. Overall, the total body water decreases as you age, right? So a newborn infant has about 80% body water. And as we age, right around the age of 65, we only have about 60%, and that's a little bit less in females, about 45 to 50% of total body water. So as we get older, We know that our intake isn't as well as it used to be. We know that our sweats and our skin defenses aren't as great as they used to be. And we go around in a chronically dehydrated state. And dehydration is not good for cardiovascular output, and it's not good for bladders or urine either, because if you're in a dehydrated state, you actually have more prone to have bacteria and UTIs, and then kidney infections as well. When we talk about the skin, the overall skin kind of ages and we lose collagen, and that's one of the reasons why you get wrinkles, is because the collagen isn't as great anymore. We lose water more freely, and that's one of the reasons why our total body water decreases. We don't have as much fat in our skin, on our skin layer rather, so we don't do very well with maintaining, moisturized skin. Normally we go around, as we get older, our skin gets drier. So, you always see these older ladies are always putting on lotion, right? My grandmother specifically, always putting on lotion. And that's because she has dry skin. No fault of her own. It's just because she doesn't have the oils and the lipids on the top of her skin in order to make it nice and smooth. The epidermis layer, which is our first layer of defense, actually decreases. And so you'll see here that there's an age spot here, like a brown spot. And that brown spot is melanin kind of groups together, and the skin is more sensitive to UV rays. So if you're out in the sun, you're going to get these weird spots, right? Some of them called aging spots, but normally it's just due to sun damage. The sweat glands and the sebaceous glands, having the oils to secrete up through the hair follicles in order to make our skin smooth, those actually decrease, and they decrease their outputs as well as their size. We don't have as much vasculature going through the skin, and we don't have the same amount of fat. If you look at the two layers, of the younger on the left and the older on the right, the amount of subcutaneous fat isn't the same. And so that's going to have difficulties with hypothermia and body temperature regulation. And to think about that, if you've ever gone into somebody's house in the summer, for those who are older, the heat's on and they're in a sweater. And you're like, geez, what are you doing? It's hot in here. Oh, I'm cold. So that's the reason why they're usually cold. The decreased epidermis, decreased vasculature, decreased sweat glands, and the changes in fat. So when we talk about this, what happens to the severity of the burns then? If we don't have the same thickness of the epidermis and our skin is thicker, that means that what might be traditionally a superficial burn or a first-degree burn, which is some redness, could easily be now a partial thickness burn or the second-degree burn. Wound healing isn't as great because the collagen isn't able to switch from type 4 to type 1. And also the tolerance for heat and cold is just not there. With the musculoskeletal system, actually at the age of 30, the bone density starts to diminish, and it accelerates in women after menopause because of the loss of estrogen. All right. Women will actually start to, shrink, and it's not really physically shrinking, but it's narrowing of the vertebrae, causing them to have poor posture. Maybe that causes some kyphosis. Maybe that also causes some scoliosis, right? The cartilage becomes thinner and less resilient. So like if I have a knee here, right, this would be my femur, this would be my tibia, I can't slide that kneecap over, and so I have some grinding going on. That also is true with people who are a little bit more overweight. And when you have that constant grinding, you start to have spurs, and that actually leads to osteoarthritis. The connective tissue, even if I'm able to move, the connective tissue isn't able to have that range of motion, so I'm not able to maybe raise my arm as high as I was before. And then the loss of height. Somebody who was 5'6" might now just go be a hair over 5 foot, and the posture isn't as well. So it's not that they've shrunk, it's because the narrowing and the bone isn't as thick as they used to be, and leading to changes. Sarcopenia is a medical term for loss of muscle, and it actually starts around 30. So that's why it's important for those, in their 20s to build the muscles, and 30s to 40s to 50s to maintain that by going to the gym and exercising. The amount of muscle decreases, and so does the size of the fiber. And when that happens, the muscle isn't able to contract as much, right? And so that causes increased stress on joints as well. And if you're talking about the knee specifically with the quadriceps femoris, or the patellar ligaments going down into the calf, those aren't easily able to flex, and so that's going to cause people to fall, right? And so we often encourage people as they start to get into the 30s, 40s, 50s to go to the gym. And even if it's walking on a treadmill, even if it's doing a rowing machine or taking two little, 5-pound dumbbells and try to do some curls, or try to do some shoulder presses, try to do something so we can continue to keep that muscle mass there and it doesn't atrophy. With the nervous system, the breakdown of the function is actually multifactorial and it's variable. So if I get to the age of 70, I might not have the same capability that Matt has when he's 70. It changes in every person. It's variable depending on what happens. Matt's had a couple more head injuries than I have, so I expect that my intellectual ability will be better at the age of 70 than Matt. So the short-term memory and the ability to learn decreases. That's where the whole saying, you can't teach an old dog new tricks come from. Because to learn something when you're in the 50s, 60s, and 70s is much more difficult because the neurons have some plaque in between them. And when the plaque is in between them, they can't communicate and fire back and forth. You start to get, the vocabulary decreases. And not to be political or anything, but when you talk about President Trump didn't have a lot of big words used. He used the same words, repetitive, and they contributed that to his age. So his mental status, he might have all his faculties, but just because of the age, whether it's President Biden or Ronald Reagan or anybody else, the vocabulary is just not there as it was in the 30s and 40s. And so they tend to use the same words all the time. And if you're completely fine, no head injuries or strokes or anything to affect your brain, usually you'll keep your intellect to about the age of 80. And then after 80, you'll start to have some little bit of intellectual decline. One of the things about this, I learned that those who are starting to have some memory loss, what we encourage them to do is start to do a crossword puzzle, start to do something that stimulates the brain, start to do a brain teaser, do Sudoku, even if it's a word search. That way you're engaging more neurons. And somebody who's at the early stages of Alzheimer's disease, we actually get them to do it. And the higher your brain capacity is, what I mean by that is the smarter you are, the more you know, the faster it is for you to forget and the harder for you to relearn things. So if you're in the 70s and you're established PhD with 5 doctoral degrees, you might have difficulty when you do start to lose those neurons. You might have difficulty relearning things. So if we can actually take a crossword puzzle and get you to start doing it in your 60s, we might preserve some of the brain function by the time you're 70. This is the brain between the ages of 42 and 82 years old. So this is a 40-year difference here. And so what happens in the elderly is the brain will actually decrease in weight. If you look at the brain on the left and you look at the brain on the right, there's more black space all the way around the skull, right? You can see that the folds, I'm going to try to outline this here. My pen's not working. But you can see that the folds have more black space in there too. That's the actual gyri or the folds of the brain. And in between there is cerebral spinal fluid that cushions that and allows the synapses to process. So if you have wider gaps, you're not allowing the communication to happen between the two folds. So you also start to get, if you look in the center, you'll see the little butterfly on both sides. Those are the ventricles, and those ventricles will actually start to get bigger and wider, and that's you're losing brain cells. And that happens naturally. These are both perfectly good brains that with an MRI, and they don't have anything wrong. They never had a stroke. They don't have Alzheimer's. It's just the physiological process of the two of them. So you can lose up to 45% of all brain cells in some areas, right? You're going to have 15 to 20% blood flow reduction. The conduction speed, it decreases. We already talked about that because you have the increased black space between those folds. So that fluid can't communicate from one side to the other. But if you start to lose your brain cells prematurely, you actually have the onset of dementia. With the cardiovascular system, this here is a picture of a heart. Somebody who actually had a heart attack here. You have a lower resting heart rate and you have a lower maximum heart rate. So with this, it used to be told that your maximum heart rate is 220 minus your age. So if I have 220 and I'm going to have somebody who's 70 years old, my maximum heart rate for that patient should be about 150. Now, the research on this is now changing. They said that typical formula that has been around for decades isn't exactly true, that we're actually missing up to 40 extra beats. So the new research is saying that 220 minus 70 should be 150, but now we can add 40 more. So that means that a 70-year-old may have a maximum resting heart rate of 190, and that'll be okay. The caution with this is we don't want to have that heart rate go beyond the maximum because the cardiovascular system will collapse. We can't maintain output, cardiac output, and we can't get the preload flowing through. We've already talked about that with the congestive heart failure lecture. But that's important to know. If you have somebody who's 70 who's tacking away to 180, that's bad, right? We already know that's SVT, but that's even worse for somebody who's that high in age. The elasticity of the walls, especially in the aorta, will not stretch as much as it is. And so if they can't stretch, they can't accommodate. And so you're going to have a higher blood pressure with that. You're also going to have calcification deposit into the aorta, and that's going to increase the systolic blood pressure as well. You can have higher systolic blood pressure with a normal diastolic blood pressure. So for example, if normal is 120 over 80, or now the new normal is 110 over 70, you might have 160 over 86. So your higher systolic is high, but your diastolic is normal. And that's just normal for these people. The stroke volume declines though, and so the speed of contractility declines as well. With this heart here, I chose this one because this is somebody who actually had long-standing hypertension that wasn't necessarily treated. You can see those black arrows. Those black arrows are showing the infarct. And so when you look at this, this is the left ventricle, this is the right ventricle, this would be anterior, and this here is the septal region. And so this person had an infarct on his left ventricle that was the anterior septal infarct. And so this patient ultimately died from not taking care of himself or herself, or going to the hospital, and they had chest pain. The other thing I want to point out, and I hit on this with our congestive heart failure, is look how thick this ventricle is, right? This ventricle is hypertrophied. And when it's hypertrophied, then that usually means that they had some long-standing hypertension that's not treated. We can find out if a patient has left ventricular hypertrophy by doing a 12 lead. And so this might help us, right? Here's a key thing for paramedics. If somebody has left ventricular hypertrophy, the only MI you can include, you'll actually be able to see, is an inferior wall MI. And here's the thing. So you'll see how long these T waves are, and you'll see the R waves in the V1 through V6, all right? So in order for somebody to have left ventricular hypertrophy on a 12 lead, you're gonna take the total of the deepest S wave in V1, V2, V3. So I'm gonna focus your attention down to here where this red arrow is, all right? You count those up. So we're gonna count those up. So we're gonna start here. So it's 5, 10, 15, 20, 25, 30. This one's off the chart, that's 30. What do I need? I need the sum of 35. And now I'm going to look at my tallest R wave in V4 through V6. And here we go. So that's 30 here, 35, 40, 45, 50. So the sum of those two are 50. That means that it makes it very difficult to find a lateral wall MI. That makes it very difficult to find an anterior wall MI. That makes it very difficult to find a septal wall MI. Not saying that you can't. However, easily overlooked, easily missed. So our bread and butter for somebody who has left ventricular hypertrophy, focus on the inferior lead, and you'll be able to see those very, very clearly. Somebody has signs and symptoms of ACS, they have the crushing chest pain, they have left ventricular hypertrophy, you've gone ahead, you give them the nitro, you're doing the Tylenol now because you know that fentanyl is not great, and you know it. You're like, oh, I know this guy's having an MI, I just can't see it, and they have left ventricular hypertrophy. They probably are. They probably are having an MI. Moving to the digestive system here, everything's all in place, from the mouth, the teeth, all the way down to the rectum and the anus. It's all affected, all right? One of the big things is the oral cavity, right? We have a big hazard there, and those are usually dentures, right? We all know if we went in to intubate somebody or at the EMT level, if we had to put in an eye gel or a King Airway, we've had to remove the dentures first. Even an OPA, you have to remove the dentures first. Dentures are a big airway problem. And then what do we say happened in the very first part of this, in anatomy and physiology? They're in a chronic dehydrated state. They don't drink enough water. So that means when somebody does take a pill or they take their medications, they're just drinking a little sip. Not only do they have difficulty swallowing, they're going to have pill-induced esophagitis because they don't take enough water with that pill in order to push it all the way down to the stomach. Then maybe they have arthritis. Maybe they're taking, maybe they're taking NSAIDs, right? If they're taking NSAIDs, well, the NSAIDs will actually block the prostaglandins, PGE, and so what's going to happen is that's going to erode away the lining that's in the stomach. And when you erode away the lining in the stomach, you start to have ulcer formation from the acid. And then you start to maybe you're going to eat something spicier. Maybe you have something that's just, that's greasy. You're going to have some acid reflux. And the reason why people usually in their older age get acid reflux is because this sphincter here, the esophageal gastrosphincter, it loses its elasticity. So when you start to get food into the stomach, the sphincter here isn't as tight as it once was, and it opens up. And when it opens up, all that acid starts to come up, and so you start to have the reflux. These patients will also have decreased liver function, and that's important because liver is responsible for filtration and processing metabolism for fat soluble and other drugs. It actually is responsible, we know this, for bile flow. And if we have decreased bile flow, it gets stagnant, and then it's going to back up into the system. And so you can actually, because of the liver being bad, you can actually have problems with your gallbladder. You can also have digestive issues. So in the small intestine, we actually have the duodenum, which is the first part of the small intestine. Then it's the jejunum, which is the second part. Then we have the ileum, all right? Well, the duodenum is responsible for absorbing iron. The jejunum is folate, and the ileum is vitamin B12. And all of those is necessary for the processes in life. So if somebody is in a chronically dehydrated state because they're not drinking water, they're constipated because, well, water helps move everything through. They're not getting the essential amino acids, the iron, the folate, the vitamin B12 for the processes they need. And they have an increased risk of adverse effects. For example, if you don't have vitamin B12, then you can have microblastic anemia, right? So there's a whole bunch of other things that are connected for a different physiology lesson, but they really do have some problems. The stomach doesn't expand as much, right? You go to one of the, let's just say you go to Denny's and you get an all-star grand slam or the super grand slam or whatever they call it today, and you get bacon, you get toast, you get sausage, you get eggs, hash browns, you get all of that. Well, when you were younger, you probably devour all of that and then some, right? Maybe you went to a Quaker Steak when they have the all-you-can-eat wing buffet and you ate 50 wings. Well, now you're 40, you're 50, you're 60, and maybe you eat 3 chicken wings and you're full. That's because the stomach doesn't have the ability to expand all the food that you eat. So people start to get full quicker. The other thing is tea and crumpets, right? Tea and crumpets, the coffee or toast in the U.S. There's such a poverty level in the United States with elderlies. They have to decide whether they want to go grocery shopping and eat food, take medication, or pay bills. And so normally they opt on taking medication, paying bills, and they kind of skimp on the food. So that has other digestive problems and other long-term complications as well. With the renal system, the actual kidneys will actually decrease in size. 66% of people over the age of 40 their GFR, the renal function, will actually decrease. So they're not filtering out that innocent drugs such as NSAID or ibuprofen. Sometimes the elderly would get sporadic contractions of the bladder and they can't control the detrusor muscle, so they have some accidents. The overall bladder capacity decreases, so people, you might be able to, work 8 hours and not go to the bathroom, but now you're taking, if you are working in your elderly, you might have to go to the bathroom, maybe 3 times, increasing to 4 or 5 times throughout the day in that 8-hour shift. they're not able to fully empty the bladder. And so that's a problem, because when you have leftover stagnant urine, that makes you susceptible to UTI. The urethra in women will actually shorten because of the loss of estrogen. In men, the prostate actually enlarges. We said that you could have decreased blood flow, right, due to cardiovascular problems. And so when you have decreased blood flow, the juxtaglomerular cells next to the nephron will actually sense that. And when we talked about the renin-angiotensin-aldosterone system, we said, hey, the kidneys are one of the primary factors in determining your blood pressure. And so if you have decreased blood flow to the kidneys, what's going to happen? It's going to increase renin. That's going to connect, and that's going to increase your overall blood pressure, even though we don't want it to happen. The glomerulus, which is this little ball-looking thing here, this glomerulus will actually, the artery will come into it, and it'll actually start to kind of bring in the waste products that it needs to have filtered out. And it'll go through the nephron. And so because of the blood flow to the kidneys isn't there, not only do we increase the blood pressure, but we don't get a chance to filtrate out all the waste that we need. So it results in decreased filtration. We already talked about the hypertension effect. But when you go into different parts of the nephron, you're going to see, let me see here, the PCT is this little part here. The PCT, proximal convoluted tubule, is responsible for reabsorbing 66% of all glucose and amino acids. So if I'm not able to reabsorb that into my body, I'm peeing all of that out. That's a problem, right? When we get to the loop of Henle, when the loop of Henle is down here, and the ascending loop of Henle, we're focused over here. The ascending loop of Henle here, that's where we actually reabsorb some of the water in our body, right? So one of the drugs that was popular for CHF that we no longer use was Lasix, and Lasix actually inhibits the reabsorption of sodium, 2-chloride, and potassium. So we would give Lasix because what do we want to do? We want to pee out the extra water, right? So if I'm supposed to, in the loop of Henle, reabsorb sodium, chloride, and potassium back into my bloodstream, and I block that from happening, I'm able to pee out the sodium. And we remember what we said. We said that for every sodium, 3 waters follow, right? That's how diuresis works when we were talking about CHF. That's how Lasix works. But we're not able to reabsorb the sodium normally back into the blood system. So what happens? We already have sodium being lost and extra water being lost through normal function. And then somebody who has congestive heart failure is put on Lasix. Now we just tax the whole system. We're losing more sodium than we need. We're peeing out more water than we need to. And it's a bad effect on the patient. That's one of the reasons we got rid of Lasix for congestive heart failure. The other, another blood pressure medicine is hydrochlorothiazide, right? Hydrochlorothiazide, abbreviated by HCTZ, acts here at this region. And what that would do is that would block the reabsorption of sodium and chloride. So again, if I'm not allowing sodium to go back into my blood system, I'm keeping it in my nephron, allowing it to pee out, the excess water that I would have will have an effect on my kidneys and decrease my overall blood pressure. So you just learned about 2 diuretics integrated with this and how they work to decrease blood pressure in extra fluid. Also in that DCT, the antidiuretic hormone doesn't work very well anymore, rather. So, you know, when you would be in a low volume state, the antidiuretic hormone will kick in and tell you, hey, I need to preserve all this water. Well, it just doesn't do the same effect as it does if we were younger. So what does a walnut, an orange, and a tennis ball have to do with each other? And why is it in this renal system lecture? Does anybody want to take a shot? Okay, so the walnut represents the size of a prostate in a guy who's 25 years of age. And that walnut is excessively large compared to the orange, right? But I wanted you to see what it looked like. A size of an orange represents the size of a prostate in a guy who is 50 years of age. And the tennis ball represents the size of a prostate in somebody who's 70 to 80 years of age. And when we have benign prostate hyperplasia, right, or we have prostate problems, or we start to kind of get problems, difficulty urinating, and you're a guy, what the first thing they do is they want to measure the size of your prostate and see what your PSA levels are. So on the left, you see a normal prostate. You see the bladder, and then you see the urine coming out through the prostate, through the urethra, and out through the penis, and that's how somebody pees. When you have benign prostate hyperplasia, BPH, what you're seeing is that prostate is now it's so big, it's actually constricting the flow of urine from the bladder out through the urethra. And so what happens? Guys have difficulty urinating. They're usually on a drug called prazosin or tamsulosin, right? That will actually help to decrease the size over time and make it easier for a guy to go to the bathroom. The problem with somebody being on prazosin or tamsulosin is that's an alpha blocker. So if we block alpha, we can't vasoconstrict. And when we can't vasoconstrict, our blood pressure doesn't increase. But also, what happens if I stand up from a sitting position too quickly? I'm going to be more prone to falling down and having a syncopal episode.
Bill Waters is fanatics.
Somebody's microphone is on. But moving forward.
What the hell are you talking about? How did you get this? Is how counted. This was right here your first name. What is it? I have no idea.
Sorry, I'm just waiting for the microphone to mute. It's right there. You can see the. I think they got it. Okay. All right. Okay. So moving forward, the immune system, right? This picture on the left. Does anybody want to guess what this is? The picture on the left is actually a white blood cell engulfing anthrax. I thought that was cool. So our immune system actually will start to overall kind of change. Okay. So we have the ability to distinguish we have a decreased ability for ourselves to distinguish internally what's us and what's something else, such as a virus or bacteria. And what happens with that is we're more prone, as we're not able to decipher the difference, we're more prone to autoimmune diseases, such as lupus, Sjögren's disease. Macrophages, which are kind of like trash cans for all the bad stuff in our body, what they usually do is they go in and engulf things, kind of like Pac-Man does. But they eat things more slowly than they normally would. And so what happens when you have bad cells and bacteria and things like that, you increase the rate of infection and you increase the rate of cancer. All right. We have fewer overall white blood cells, and our antibodies just can't get to where we need them to go to reach the invaders. Right. So we have more increase of pneumonia, flu, and other viruses or bacterial infections. So that's why vaccines and boosters are essential for the elderly population. With the respiratory system, we actually see decreases in gas exchange. Our overall vital capacity, meaning the amount of air we can totally breathe in and use for function, decreases. And when that happens, we have an increased risk for pneumonia. We have weakened respiratory muscles. And when that happens, we're just not able to take a deep breath. We're not able to kind of overcome some of the challenges. And with their weaker, we tend to become fatigued even longer, or even sooner, rather. Our oxygen uptake decreases by about 70%. And we're more prone, because of the smoking, a lot of patients in their age 65 and older have COPD or emphysema or other chronic lung conditions from either working in factories and with silicosis, barriosis from aerospace, or maybe it's just anything, coal miner's lung from working. Because before, the late 80s, 70s, 90s, they went into the environments, the steel mills, they went into the coal mines. They just didn't have the OSHA regulations that we do today. One of the things that I want to hit on is pulse ox. And I think all of us have been taught about pulse ox when we were in EMT school. But I want to kind of caution you on pulse ox in the realm of low hemoglobin, right? So what I want to say is when you put that pulse ox on the finger, it's reading the amount of oxygen that's attached to hemoglobin. And if somebody's anemic, somebody's low in blood, it's pretty much without saying that they have low hemoglobin as well. So what happens is, let's say that this is a blood cell and I've got 4 hemoglobin sites, which is normal. And attached to this hemoglobin, I have oxygen, right? So if I put a pulse ox on this patient, what does it read? It reads 100%, right? My pulse ox is 100%. If I use that same patient, and now I have 4 hemoglobin sites, sorry, I'm writing on this upwards, right? And I only have oxygen attached to 3 of those 4, I have a pulse ox of 75%. It's kind of easy like that. But what happens when I have a blood cell and I have only 2 hemoglobin and oxygen attached to those 2 hemoglobin? I don't have hemoglobin attached to the other side. My pulse ox in this patient, because of the amount of oxygen attached to the hemoglobin, my pulse ox is still going to be 100%. But what don't I have? I don't have the ability for that red blood cell to carry the amount of oxygen that my tissue needs. And that's important. And that's something that kind of came of concern over the past week with some patients. So somebody who is low on blood, you assume that their hemoglobin is low as well. If they're saying they're short of breath, they probably are. Regardless of what that pulse ox says, we want to make sure if they're symptomatic respiratory distress or symptomatic breathing, increased work of breathing, go ahead and put on one pump oxygen, because the chances are they probably need that extra oxygen. With the endocrine system, hormone levels can decline, or the receptor can actually lose its sensitivity and not accept or not recognize that hormone. Most of them remain pretty normal, but a couple things: you have decreased estrogen when ladies go into menopause. You have decreased testosterone as men age, and so that's going to decrease some strength. The growth hormone overall decreases, so that leads to decreased strength and energy. And you have decreased melatonin production, so that affects your circadian rhythm. So that's why, if you ever think about it, you have elderly females or males who are in up at 4 a.m. They go to bed early, they rise early, or maybe they're up at different hours, and that's their circadian rhythm is off. Your thyroid, your TSH can be off, and you just look at somebody. When you do a physical assessment, look at their nails. Do they look normal, or do they have pits and ridges in them? Look at their hair. Is their hair brittle? Do they have eyebrows, right? If they don't have eyebrows or losing eyebrows, that could be a thyroid problem. So when you do your physical assessment, you really honestly do a head to toe and look for things that we might take for granted. You might pick up on something. So with medication, we've all seen this picture right here. What kind of medications are you on? They either go and they grab a basket and they say, here, it's in a Ziploc bag, here you go. There are a bunch of pills in a Monday through Sunday container, and you have no idea what they are, or they just bring you all the bottles. And when you look at the bottles, they're repeat drugs that were from 3 refills ago that still have pills in them, and they're usually confused. And on the top, they write day 1, day 2, morning, noon, night, whatever. And so they have a lot of polypharmacy. They have a lot of medication that they take, but they're often confused with when to take it. Of the age 65 years and older, 90% take at least 1 drug a week. 40% take at least 5 drugs per week, and 12% take 10 drugs per week. Usually women have more medication than men. And those who are frail or hospitalized, in nursing homes, they usually take the most, which is why the nurses go around with the med card. Of those, they usually take about 7 to 8 drugs daily. They just pop them out of the pill packs, they put them in a little cup, and they assume that you take it, right? But the problem with multiple medications is that even over-the-counter drugs can have some interactions with them, and they can be pretty hazardous. One drug may have a side effect because it interacts with something else, right? So, for example, NSAIDs or celecoxib, which is a COX-2 inhibitor, they will actually worsen heart failure. And actually, celecoxib was taken off the market through over the counter rather, because it would cause vasoconstriction and it would actually cause some people to have a heart attack. Another thing is antibiotics and warfarin or Coumadin. Most antibiotics will cause the blood to become too thin, the INR will be elevated, and then some antibiotics such as rifampin, which is given for prophylactically for Neisseria meningitidis. So you have somebody in a dorm room, right? They get meningitis, and now they had a party over the weekend. Well, then everybody who was exposed to that patient gets this drug called rifampin. But rifampin and Coumadin will actually, it'll prevent the Coumadin from doing its job. So you actually have a risk for clots to form because it's not doing what it needs to do. somebody who's on a mood stabilizer, an MAOI, that increases serotonin and dopamine receptors, or the levels of those. And they eat food with tyramine, such as cheese, wine, or fermented foods. Well, they don't know any better, so they do that. So that actually puts them into a hypertensive crisis. And then maybe somebody's drinking some chamomile at night and they're taking Coumadin. Well, they don't realize that by drinking the chamomile, now they go to bed and they shut off the light and they trip and fall and hit their head. Now that increases the risk for bleeding, have a pretty increased adverse effect. So, on top of all that, real quickly, I just kind of wanted to hit on, this is a very elementary drawing here. Why is it that we always take patients who fall and hit their head on Coumadin to the hospital, right? Why is it that we do that? And then everybody's either been on an ambulance where you go to a nursing home, fall and hit their head, they go out. It's like, oh, they're perfectly fine. Well, yes, they are perfectly fine in that situation. However, it has to do with the long-term effects. Let's say there's a small bleed, and you and me is probably not no big deal. But in the patient who's on Coumadin, it's a very big deal. And the reason is because of the clotting factors. So if I were to cut my hand here, I would have primary and secondary hemostasis, right? So the primary hemostasis would be platelet plug formation. I'd have a platelet, I'd have some receptors, I'd have more platelets together. Once that stops the leak, I want to make sure that leak is actually sealed, right? So when I seal it, I need to have the clotting or the coagulation cascade. So very quickly, your clotting factors are, let's just say 12, 11, 9, 8, so we have 10, 5, 2, 1. And I know this probably is a little weird, but what happens is these are your extrinsic and these are your intrinsic. So what happens with Coumadin, the extrinsic and the intrinsic, they come together to form the common pathway. And when the common pathway happens, then where we go is we can actually form that mesh, or the fibrin mesh. So when you have Coumadin, it actually takes out the clotting factors 2, 7, 9, and 10. So that's the problem. That's why everybody falls and hits their head on Coumadin, is taken to the ER to get a CAT scan. The reason is there's no ability for this patient to clot if they were to start bleeding. So on somebody who has a bleed on Coumadin, they're giving vitamin K, they're giving fresh frozen plasma, because that contains the clotting factors that they need in order to stop the bleed. All right. So just a little bit of physiology and pharmacology there for you.
Hey, Larry.
Yes.
Is there any other anticoagulants other than Coumadin that should be concerned about that?
So Coumadin is one of the worst ones because it affects the intrinsic and the extrinsic in the common pathway. Heparin does the antithrombin, and then you have certain ones like dabigatran or Eliquis. The generic names actually have an XA in there, and that's factor 10A. So when we go back to that, the newer anticoagulants are better for the patient. Let's say, why is somebody on Eliquis versus they're on, Coumadin? Well, Eliquis will affect usually factor 10A, which is here. So what happens, I still have 2, 7, and 9, and all I'm affecting is 1. So the newer anticoagulants, although they still pose a risk, they're not as harmful as Coumadin, because Coumadin, you've knocked out every single type of way that the body can clot. So yes, all anticoagulants are concerned. Coumadin is one of the worst because of this reason right here. So when you're assessing a patient, it's very hard to assess an elderly patient, all right? We got to figure out what's going on with the patient. They might have multiple problems. They could be altered, or they might present in a weird way. They can't really communicate well, and we've already talked about them being on different medicines. But with response and multiple things going on with them, typically these patients, they know if they go to the hospital, they may not come, well, they think, let me rephrase it, they think that they may not come back from the hospital. So they typically only call or go to the doctor for big things or for only one small problem. But things pile up and they don't realize that they're related. And most of the time, they just think that it's because they're getting old, right? So this chest pain, you might just say, oh, I'm getting old, no big deal, when really it's a sign of a heart attack. So they delay seeking treatments, right? They really say that their problems aren't that big of a deal. And, when we talked about this earlier, that 85% of the people who are over 65 years of age have one chronic problem, and 30% of the people have more than 3 problems. So that's kind of a concern, and they all kind of are tied in together. One illness obviously may contribute to the other, and we know that from basic paramedicine. The symptoms of one disease process might mask the other, right? So there's a thing called a silent MI, where maybe the female of elderly female is just complaining of shortness of breath, but you just contribute because she's had a cough for a little while, and you say, oh, it's no big deal. You're going to give it to the EMT. You never do a 12 lead, but yet that's the only symptoms they have, and they're having a full-fledged infarction. And when we treat one problem, we're typically masking another. So we really got to dig deep and try to connect the dots with these patients. So pain in the elderly patients is diminished, or sometimes maybe they won't even feel it, right? The temperature regulation is depressed. And we said that's because they have decreased skin. They don't have the great vasculature. They're unable to sweat as much as we're able to. They have decreased subcutaneous fat. And they're kind of always around in the dehydrated state. But they might not feel that they're thirsty, all right? So we need to make sure that we educate them, hey, make sure you're drinking your water and things like that. They can have increased susceptibility to confusion, right? Sepsis is a big thing in the elderly population, especially if you have a urinary catheter, especially if you have an open wound. So very quickly, they can become confused. They can also become restless because they're in some pain, and they can maybe have some hallucinations because of polypharmacy or things that are going on with them. They have an increased susceptibility, just overall, just not looking right and going downhill. And usually when you ask somebody what's going on with them, they're like, oh, I just don't feel well, right? One of the ways that I've kind of changed my assessment technique is when I walk through the door and say, hey, I'm Larry, and this is Matt, and I first thought, how can we help, right? Then when they tell me, oh, I've got a little bit of pain here, instead of saying, okay, do you have this, and that, I say, what else? Go on. So either say what else and go on. And by saying what else or go on, or reassuring them and like you're actively listening and say, okay, go on, they'll tell you everything that you want to know and probably then some. So you don't have to dig deeper to figure out what's going on with this patient. So listen to them, ask questions when appropriate, but maybe your best question to ask is, can you tell me more? Or keep going, or what else? Okay, and you'll find everything else that you need to know. And when you talk to these patients, just like you would talk to a kid, what would you do? You would stoop down in front of them so you're not hovering over top of them. You'd get in their line of sight, and you'd make sure you're able to talk to them in an environment where they're able to hear you, right? So do the same thing with the elderly population, all right? Don't assume that they're deaf, and I usually have a loud voice to begin with, and usually when I walk in, I'm pretty commanding, and so I'm like, hey, what's going on? You don't have to yell, I'm not deaf. Oh, my bad, right? And I've had that quite a few times. So just kind of talk normal, or what you think is normal for you, and see if you need to adjust how you're talking. Most of the time, they'll tell you, hey, I can only hear out of this ear, so move yourself over and talk. The other thing is you should be right in front of them, because as we age, the peripheral vision goes away. So you should see right in front of them and be right there. But also, maybe these people are depressed. Maybe they are afraid of losing their independence. Maybe they are depressed because they know that there's something's going on, their fear of diagnosis of cancer, right? And sometimes they're not very cooperative, but we have to try to get them to want to go with us to the hospital. I had a patient a couple of months ago who fell, and the fire department had to, break into the house. And here she didn't want to go to the hospital, even though she had back pain. She had back pain so much that she couldn't move her feet. So the fire department put her in the chair, and she's like, I'm not going to the hospital. The whole family came over, and all it took, she's like, I'm not going to the hospital because I know if I go to the hospital, I'm going to keep me in that damn hospital for 3 weeks or for 2 days. I'm going to go to rehab. I don't want to go to rehab. I've already done that. And it doesn't do crap. What are they afraid of? They're afraid of losing their independence. They're even more afraid of losing their house and everything that they worked for. Do you know when I showed up, do you know how I got that patient to go to the hospital? I said, look, you're obviously in pain, right? Yeah. Do you think you'll be able to go to the bathroom? Oh, I know I won't be able to go to the bathroom. How about we do this? Let's not worry about anything else. Let's just go get an x-ray and see if it's broken. You know what? I can do that. Let's go. We got to go to the hospital. But all that worry and all that trouble and everything like that, maybe it takes somebody to kind of like flip the script, let them know, reassure them, let them realize that, yeah, I probably can't do this on my own. And then, yeah, did I lie to her? Nope. Because you know what the hospital's going to do? They're going to do an x-ray. And then beyond that, it's kind of out of my hands, right? But I didn't lie to her. I got her to go, and she ended up actually slipping a disc, and that's why she couldn't move. And so she had a previous fracture as well, and that kind of caused problems with her. But anyways, you just have to maybe think about rewording your statement to them to get them to go to the hospital. So again, probe for specific complaints, excuse me, but also the best question you can do is say, what else, or keep going, or go on. And nod and reassure them that you're listening, right? They won't volunteer information until they expect you to want to know more. So make sure you do that. And if you still can't get forward with them, just start asking. If you got to go, do you have a headache? Do you have any blurred vision? You got to go from system to system, head to toe. Do it. You're going to find something that they're not telling you, more than likely. So, of course, what we typically do is normally with these elderly patients, the family's there and they want to kind of harp at you and say, you need to go to the hospital, on the power of attorney, blah, blah, blah. Hold on. Let me talk to the patient. Make sure you talk to the patient first and you talk to them and figure out what's going on, right? If you can, talk to the patient alone, because maybe there's something they don't want to tell the family. Maybe they're embarrassed. Maybe they're afraid. Be formal, be respectful. And, I usually ask them, hey, my name's Larry, what's yours? Oh, my name's Patty. Do you like to be called Patty? Yeah, I prefer Patty. A lot of people get upset if you say Mr., Sir, ma'am, even though that's very respectful. Sometimes they have a negative connotation with that. And absolutely do not use honey, dear, whatever. A lot of these people, they don't like pet names. So get that rapport, figure out what they like to be called. Hey, I'm Larry, you're Patty. Okay, so tell me, Patty, what's going on today? And that'll build a great relationship for that time and also moving forward to the next time that you probably have to go there. And again, stay in their line of sight. All right, so with difficulty for communication, we want to make sure the light source is behind the patient, all right, because their eyes can't accommodate as light as forward. So I might be squinting, and then if I'm squinting, I can't see you, I can't see the provider, I can't see what's going on. So make sure the light source behind the patient. Look at the patient, reassure them by nodding your head and saying, okay, I understand. Try to reduce the background noise. Speak slowly, and that's something that I had a difficult time in my life, speaking slowly. So speak slowly, and with them, I really try to speak slowly. Enunciate clearly. Don't assume that they're deaf by talking loud. Don't shout, and don't assume that their confusion or disorientation is them just being senile, right? So give them the respect that they need, just like you would your own mother or your loved one, and you'll get what you need, and you'll be a better provider for that. Sometimes it's difficult to get all the history, right? They might have a pamphlet, the cardiologist put them on this medication, the kidney doctor put them on here, but my PCP put me on this. They might not really know all their diagnoses. And so how many times have you gone into a patient and you said, hey, what kind of medical problems do you have? None. You say, okay, do you take any medications? Oh, yeah. What do you take? Oh, I take lisinopril. What's that for? Oh, that's my blood pressure. Or I take aspirin. What's the aspirin for? Oh, for my heart. So you got to kind of dig a little bit. But they don't really assume diagnosis the same way we do, right? They think that because they're being controlled, they no longer have that problem. The medications may be issued from one doctor in the ER to the primary care physician. So they might be different dosages of the same medication. Some might be old, some might be current. Again, we've been there where you bring out all these medications and they have multiple prescriptions of the same medication. They haven't finished the first one, but they automatically got a refill because they know that's important. Sometimes if they're short on money, maybe the husband and wife, they both take a medicine and they share that. That's really not good. Sometimes they split and they divvy up their medication because they just can't afford a refill. And then they're always trying to save money and they always want to try the less severe approach. So maybe they go to the dollar store or to a Rite Aid or Walgreens, wherever, and they get some over-the-counter medication. And when they take that, it actually has more interaction with what they're doing or maybe some adverse outcomes with their diagnosis. With the physical exam, we want to make sure, we already said they can't thermoregulate very well, so we make sure we examine them in a warm area. They could fatigue easily. So again, it's always kind of been the golden rule, do not walk your patients to the cot, but please do not walk these people to the cot. The cardiac capacity doesn't have it. They're probably on something that affects their blood pressure, and they can fatigue very easily. Right? They may not be able to be comfortable when you sit them on the cot, so ask them, hey, can I sit you up? Can I bend you in the right position? Make sure you keep them covered. And again, they can't really receive pain or receptive pain very well, so make sure you do a thorough exam. And here's the thing, if they say something hurts, then it hurts a lot, and you must probably get down to the bottom of it and figure out what's going on. Some misleading findings, the skin, right? We always usually check skin turgor, right? So if I check the skin turgor on my hand here, it bounces back. But if I check the skin turgor on a 70-year-old, it might stick up. And I might think, oh man, they're dehydrated, I gotta give them fluid. No. So the skin, what do we say? It loses collagen, loses elasticity of the hand. So what we want to do, we want to assess the skin turgor over the cheek. Go ahead and pinch. And normally, those rosy red cheeks will go right back to what they were. If they tent, that's a problem. Sometimes mouth breathing mimics dehydration because their tongue gets dried out, the mucous membranes are dry. That's one of the things, like with congestive heart failure and things, or maybe ACS. When you're giving that nitro, whether it's powder or powder or tablet form, look at their hydration status of their mouth. All right. If they're dry, that's going to have more difficulty dissolving. Look for pedal edema from inactivity. Right. I'm going to rule out CHF, depending where they're at. They might have some normal fluid in their lungs, just a little bit of crackles or rails in their bases, and that could be normal for them. And their peripheral pulses might be diminished just because of over time and atherosclerosis of their arteries in their feet. But go ahead and make sure you do really have those MSPs times 4. So in the last half hour, we're going to talk about some specific problems and that are common. These relapse or repeat some of the things they already talked about, but they're worth addressing separately. So I think it's important. With respiratory distress, we know that some of these people have a bad emphysema. They have bad bronchitis and asthma. They usually know how bad it is. They usually call you when they've taken 3 puffs of their inhaler, when they've done their nebulizer, and they know that they better get to the hospital because if they don't, they're going to end up in the ICU. I went to a CHFer. I had a paramedic student with me quite some time ago. She said, I don't want to be intubated. Last time I waited this long, they intubated me in the ER and I was in the ICU for a week. And so, okay. She's like, don't intubate me unless I stop breathing or unless you absolutely have to. So we were able to, obviously, what do we have? We have CPAP now, which works wonders. And she did well on CPAP. They were able to get all the fluid out of her and she was able to not be intubated and didn't have to really stay in that ICU. But they know what's going on with them. All right. Respiratory distress, though, can be, pulmonary embolism. It can be acute MI. And it can be something simple as pneumonia. So you just got to really assess the whole picture and figure out what's going on and dig deeper. With pneumonia, it's the 4th leading cause of death in the geriatric population. And normally it's 50 times more common in nursing homes, right? So I usually call nursing homes a petri dish because if one person has it, especially in that room, that person next to them are going to have it, and then that nurse or that caregiver is going to take it to somebody else, or at the dining area, they're all going to get the same thing. They could have an atypical presentation, right? The cough might be there, but they might not have a fever. And why might they have a fever? Because the hypothalamus is altered, and they're not able to raise their body core temperature in order to fight it. Epigastric pain. They might have some epigastric pain that they think is just digestion, GERD, but really it's chest pain, right? And they might be having a heart attack. COPD is the 5th leading cause of death for males, 55 to 74. Usually those are your smokers back in the day. But remember what happens to the COPD patient, they have a barrel chest. And so when they cough and they cough so hard, they can actually rupture the membrane and have a spontaneous pneumothorax. And so when that happens, they'll actually decompensate pretty quickly because COPD patients don't have the respiratory reserve volume like you and I do. Pulmonary embolism. Here's the key thing. If you have a geriatric patient, they're suddenly short of breath, they have decreased mobility, and you can't figure out anything else, you have to assume it's a pulmonary embolism until proven otherwise. For the paramedics out there, the advanced, you want to interpret a 12-lead. EMTs, you can go ahead and do a 12-lead transmit to the hospital. Here's what I want you to look for, right? The saying is S1Q3T3. That's the saying, S1Q3T3. You do a 12-lead. What you're going to do, you're going to look in lead 1. You're going to see an S wave in lead 1. In lead 3, you're going to see a Q wave, which would mimic an MI. You're going to see that Q wave in lead 3. and you're going to see an inverted T wave in lead 3. If you see this, it's a good rule of thumb to assume the patient has a pulmonary embolism. So again, in the geriatric patient, acute onset of shortness of breath, they're really not moving around much. What do you have to do? You have to assume that it's pulmonary embolism. Do your 12 lead, S1, Q3, T3, look for that, run them to the hospital. Lung cancer is a big cause of respiratory distress and has the highest incidence in the United States throughout the whole world, right? We had the Industrial Revolution, we had a bunch of steel mills, we were a thriving economy, and just like my grandparents, both of them came down with cancer. Neither one of them smoked. They both worked in the same steel mill. They both died. So, you know, the OSHA regulations weren't there, but they were, you know, other people work in coal mines, they work in these plants. And so that's what causes these elderly population to have the lung cancer incidence. Greater than 65% of people greater than 65 have lung cancer. And they might just have some shortness of breath. They might have a little bit of coughing out blood. They might have a chronic cough, or some weight loss. My uncle, who is, he's almost 70 years old, he had a cough for 3 months. Never went to the doctor. He just thought it was seasonal allergies. We finally pick him up. We take him to the doctor. Luis, you have cancer. You have lung cancer. So he's currently on a treatment plan and he's doing better. But don't overlook the small things. Don't let the elderly population overlook the small things. They call 911 because they have a cough for 3 months. Take them to the hospital. We might not like it, but go ahead and do that. Dyspnea, shortness of breath, that could be the only symptom of an MI. So again, just because maybe the pulse ox looks okay, you decide, you know what, I'm not going to do the 12 lead. They've got a cough. I'm just short of breath. Do the 12 lead, rule out the MI. I can't emphasize that enough. So maybe it'll present a CHF, a shortness of breath from CHF, right? But maybe they might also have the acute abdomen, which is the sharp pain in the abdomen. Maybe it's going to be tender, maybe it's going to be rigid. Any of these signs are indicators of the silent MI. When we say silent, that means that they don't have the chest pain that we would typically have. So rule that out. And we know as providers, if you should do a 12 lead in any abdominal pain, shortness of breath, syncope, blood pressures, we know that, right? But yet providers are still not doing that. I just can't understand why. All right. Also, the silent MI can present with weakness. Maybe they're fatigued. Maybe they just passed out. Maybe it's incontinence, right? Maybe they're going to have like a TIA or a stroke. Maybe we're just confused. So all of these things we would typically do a 12 lead for anyways. So why aren't we catching these? Why aren't we doing these? I don't know. Ask your partner. Ask somebody who you know who doesn't do it, because I don't know. We talked about congestive heart failure in depth. There's a whole separate lecture on that. But just know that the signs and symptoms, you know, nocturia, they can't breathe at night. I'm sorry, nocturia, they go up to pee at night. They can't lay flat. They have orthopnea. Maybe they have some confusion at night because they're not getting the amount of oxygen they need. Sometimes they're going to have pitting edema. Maybe they'll have edema on the back of their sacral area if they lay in a bed. Maybe they'll have some blisters in the legs as well. A lot of patients can have dysrhythmias, all right? We already talked about the maximum heart rate is decreased. And the overall heart rate is decreased. They don't take the extreme rates very well, right? And when you have the extreme rates, the AFib, the RVRs, the 130s, 140s, tachycardia, you might cause CHF, you might cause TIA, you might cause a stroke, you might cause a heart attack, right? Consider the hypokalemia, some of the other electrolytes, okay, especially on patients in diuretics. We learned today Lasix affects sodium, potassium, chloride. We learned that hydrochlorothiazide affects sodium and chloride as well. Plus there's a whole bunch of other ones. But just know, if they're on a diuretic, do the 12 leads, make sure nothing's wrong with them. All right. Also drug toxicity, maybe digitalis. Right, digitalis. If you have a digitoxicity, somebody's going to have some yellow vision. Like I say, everything has a yellow view. Right, you're going to see some EKG changes, which I have later on. Maybe beta blockers. Right, maybe they took too many beta blockers. Now they're bradycardic in the 30s, 40s, and then maybe they're calcium channel blockers to regulate their heart rate, to regulate their blood pressure. They overdid it in their bradycardia there too. Cardiovascular disease with aneurysms are big in the elderly population. Again, we already talked about that they have the calcifications of the aorta. The aneurysm is the bulging out, and the dissection is the tearing of the wall, the inside of the wall, the vessel, all the way until it gets through all three layers, the tunica intima, media, and adventitia. So it's going to work its way through those three layers. And when that happens, it's going to bulge out to the side, and it's going to rupture. And with rupture, they'll be in cardiac arrest within seconds, and there's almost nothing you can do unless they're already on the landing pad of the cardiac center, and they can take him into the operating room. So with the thoracic aortic dissection or aneurysm, normally dissection because that's when you feel it. The dissection, you're going to have tearing chest pain. All right, and sometimes with that, you can have neurological signs and symptoms because you have the aortic arch, and off the aortic arch, you have your brachiocephalic vein that goes up to your carotid artery into your subclavian, and then you have your subclavian, and then your other carotid artery. So depending where that rupture is in the thoracic region, if it's on the arch or beyond the arch, you might have differences with extremity pulses, differences in blood pressures. And you can also have decreased the ability for blood flow through the carotid to the brain, so you might be altered. With the abdominal dissection or the aneurysm, you're going to have tearing abdominal pain. When you palpate, you're going to feel a mass on the stomach. They might have some unexplained low back pain, and maybe their pulses in their feet aren't what they were, not as strong as they were. So again, MSPs times 4 becomes all that important in the elderly population. We already talked about hypertension. We know that a lot of patients have it. We know that they're on medications, and we know that those medications may complicate other things such as the diuretics and making them electrolyte imbalance. Syncope. When we talk about syncope, we can have the changes of mental status for whatever reason causes the syncope. The morbidity and mortality is higher in the elderly population than it is in the young population because it leads to trip hazard, leads to falls. Usually they're found by themselves. All right, maybe it's cardiogenic, okay? Maybe it is from that silent MI. Stokes atom attack, what that is an abrupt change in the heart rate, whether fast or slow, that decreases perfusion to the brain, and so they pass out. That's Stokes atom attack. Maybe they're too fast, maybe they're too slow, maybe the SA node is giving out in sick sinus syndrome, or maybe the beta blockers that they're on for their hypertension is causing them to pass out. So dig deep and figure out what's going on. It can lead to strokes, it can lead to TIAs. Maybe a seizure caused them to have a syncope. And then maybe they're straining so much to go to the bathroom that they're vasovagaling themselves out. Maybe it's simply due to volume depletion. We talk about the elderly as chronically dehydrated. Maybe they just are more dehydrated today than they were before. Or maybe they have some sort of GI bleed that they didn't know about. Real quick about GI bleed. If you're on the, let me see here, so the left side. So if you're on the right side of the ascending colon of your large intestine, right, the right side, and let's just see. So I've got, okay, here's the, okay, this is the anus and the rectum. So this is your ascending, this is your transverse, this is your descending, this is your sigmoid, okay? So what happens after everything happens and you take all the nutrients out and you start to form stool, what happens over here in the ascending, which is your right side, you start to get water that comes in. And so water will come into the large intestine and it'll start to kind of hydrate the stool so we're not constipated. One, if you're already dehydrated, that doesn't happen well. That leads to constipation, that leads to straining. But two, water comes in. So if you do have a GI bleed on the right side in that ascending where things become mixed up, you may not find out. It may come out as a normal brown stool. Because what's going to happen, you're going to take everything, it's going to mix up, it's going to go from liquid on the ascending to the transverse, and then it's going to start to dehydrate itself as it comes down to the descending, so you can have a stool formation. Usually with left-sided GI bleed, there'll be bright red blood. You can find that out, all right? And then also with coffee ground emesis, we consider that an upper GI bleed. That's anywhere from the mouth all the way down to the first part of the duodenum, I believe, at least to the duodenum. And so when you have that coffee ground emesis, that blood that has been digested has been sitting for about 9 to 12 hours. So it's not something that's acute. You know, we talked about the strokes. We had a whole lecture on strokes. So again, suspect a stroke in anybody with an altered mental status. Go ahead and do your FAST exam, right? Everybody's going to a FAST exam. If you have the abnormal arm drift or you have paralysis one side, and I think most everybody on the call has the Van exam, go ahead and do the Van exam to see if it's a large vessel occlusion. Parkinson's. Parkinson's is the fourth most common degenerative disease in the elderly. Okay, it affects the basal ganglia of the brain, and what that means is people aren't able to move as well as they were able to. It can be primary, and what you're seeing on the bottom is you're seeing what's called it's a part of the midbrain, the substantial nigra. And so nigra being black, you can see here, this is normal when that's colored. And so when that's working, that actually allows dopamine to do its function. When you look at somebody in Parkinson's disease, we don't see that black substantial nigra, all right? So that means the dopamine is overall decreased, and dopamine is necessary for movement. So if you don't have dopamine, you can't move well. So these patients are rigid. They're not able to move very fluidly. They have shuffling feet or that shuffling gait. They might also have a pill rolling tremor. They're going to have these tremors, and they're just going to do that. So you're going to see what they look like. When you see a Parkinson's patient, you're never going to forget it. We've already talked about dementia and delirium in the psychology aspect of this refresher, so I don't want to hit on them as much. Just know that dementia can be structural in origin. It's very slowly to progress, and when you do have dementia, it's irreversible. With delirium, usually there's something in the body that caused it. It could be drugs, it could be metabolism. We can fix that, so that's something we want to look for, all right? Dementia is global, and delirium is it's focal. So global stumbling, okay, global acting weird, all right, that's dementia. Delirium is something that's acute, happens very rapidly, and normally it's one certain thing that's weird. All right, let's go through this. All right, Alzheimer's, that's one of the leading causes of dementia in the elderly. So you have 3 stages. You have an early, an intermediate, and then a terminal stage. The early stage, you start to have some recent memory loss. You're going to have the inability to learn new things. You can have some mood swings, all right? And that's the mood swings are usually where people start to pick up, hey, I need to take somebody to the doctor. They're going to rule out delirium versus dementia, and then they're going to go out and do some more tests and maybe diagnose with Alzheimer's. The intermediate stage, right, is when you're going to completely lose the ability to learn. You might, those people who walk out the door, who don't know where they're going or driving the car, they have no idea. That's the intermediate stage. And then the terminal stage is when they lose the ability to walk, they lose their bowel and urinary function, and they don't know how to eat anymore. Joe talked at length about diabetes. Just know that it's pretty prevalent in the elderly population. With thyroid, normally about 2 to 5% of people develop hypothyroidism, and less than a third have the typical signs and symptoms. And when we say hypothyroidism symptoms, we're talking about fatigue, loss of energy, brittle hair, loss of eyebrows, brittle nails, things like that. The abdominal pain, also known as acute abdomen in the elderly, we want to make sure that we examine that because frequently it's a surgical emergency. All right, maybe they're altered, maybe there's an unexplained sign of shock with no trauma or bleeding that's present. All right, but again, we want to make sure it doesn't mimic something else, right? The acute abdomen doesn't really mimic the acute MI that the patient's having. So again, dig deep and figure out what's going on with the patient. We talked about GI disorders. So again, a GI bleed can be anywhere from a peptic ulcer to NSAID abuse to ischemic colitis, be anything. But we need to make sure we ask some questions to figure out what it is. The bleeding signs, I already talked about the coffee ground emesis. That's digested blood from the mouth anywhere to the first part of the duodenum, and that's usually about 9 to 14 hours that it's been sitting there. And eventually, just like we would regurgitate anything like food poisoning or something that doesn't sit well, it comes back up. And it comes back up as those coffee ground emesis. If it's dark or bloody stool, that stool that's been going on in the intestines, that kind of comes out. The formal name is melena. So that kind of happened, and that stool didn't get dehydrated. So it comes out all greasy and dark. Again, Why are they falling down? Maybe their blood pressure is low because they have the GI bleed. Here's a bowel obstruction. They were going into the intestine here to remove a bowel obstruction. And typically it's in the small intestine. And sometimes it can be from recent surgeries, adhesions, maybe it's medication, maybe it's like constipation that we talked about. But one of the big causes is food. When food causes a disruption, it's called a BSOR. So food like celery, potato peels or skin, and corn, they don't get digested. If you eat corn, look later, it's not going to be digested. So what happens is as they go through your body, they don't get broken down. And so they start to form a little obstruction as you eat, and it gets stuck in part of that. And so what happens, that BSOR, or that obstruction, causes everything to back up. Sometimes the bowel will start to twist to try to, as it's making so much force to try to move the food through. And then you can have some complications. But something that small that you see in picture C is what's causing life to stop and to have to go to surgery in order to get it fixed. All right, we already talked about the sebaceous glands and oil and the skin and things. That's why they're always itching. There's a slower healing process, so they can't, they have an increased risk for infection. The incidence of fungal infections and herpes zoster increases, right? Herpes zoster is shingles. So normally you'll see a shingle on a dermatome, maybe the chest, maybe the face. They'll be very painful. Looks like red dark blotches. Some home remedies may cause some skin disorders, all right? So just, whether they want to use honey on a wound or whatever, maybe that honey that they think is healing that burn that they have from getting the pan out of the oven is actually causing more of a rash. So we got to figure out what's going on with that. And so if we were to have somebody who maybe was stung by a bee and they start to get some hives on them and we give them Benadryl, maybe the antihistamine is causing them to actually have an adverse reaction such as a low blood pressure and syncope because it has some alpha blocking properties. Decubitus ulcers, typically, we don't have to worry about this too much, but they do happen in nursing homes, about 25%. Your interfacility transports, this is why it's important because you'll see there's various stages here, but mostly in bony prominences at the waist and bedridden patients. And how you fix this is make sure you're turning patients. And then if you do have to take care of it, you're going to clean it and you're going to pack it and allow that wound to heal on the way out as it heals from the inside out. Osteoarthritis. So it's the leading cause of disability in the elderly. You get some joint pain and it's worsened by movement. So the mobility, people with bad knees, they usually get off the ambulance pretty quickly because they don't like jumping up or, getting up into the back of that. So they can't move well. It doesn't work. It doesn't move very well. And there's a lot of tenderness there. But the problem is not doing anything and being immobile will actually worsen it. Okay. So for these patients, physical therapy is good. NSAIDs are good. Now there's new medication like a gel that you can put into for the cushioning of the knees that works very good. Osteoporosis, worse in women than men because of the loss of estrogen. And the 4 bones on the bottom, I want you to look at the inside of here. Those are called the calyces, the cortices there. And so the bones will actually start to kind of, from lack of calcium and mineralization, they'll actually have large, looks like spongy bone. And so what was once normal over here now is over here with a bunch of gaps. And so that will cause the bone to be more brittle and cause more chances of fractures. So how do we fix this? We encourage people to actually do weight-bearing exercises to build that bone back. All right. And then toxicology pharmacy, so typically people will not mention every single drug that they're on because Tylenol is just Tylenol. I don't need to list that, right? But, we need to make sure they're compliant with the medication. We need to make sure they're taking it as directed. And that is actually transforming to a whole big movement in the pharmacy world. So what was a bunch of maybe 10 vials of medicine now is maybe in a little packet that they rip open and it says morning, noon, and night. And all their pills are there. They just know they open this little packet and they put it in the mouth and everything's good. A lot of pharmacies are doing that. And I know like Amazon pharmacies able to ship that to your house like that. And it works really well because it decreases the risk of actually taking too many and it's usually on automatic renewal. So just finally, with a couple extra drugs that we might give, lidocaine actually will, if we give lidocaine for maybe some PVCs or they give it in the hospital for any other reason, the liver doesn't work as well, so it's going to back up into the body, causing some toxicity. And when it does, it's going to have some CNS-related symptoms. So there's going to be some numbness and tingling. Maybe they'll be drowsy. Maybe they'll have some depression, some muscle twitching, or some seizures. Beta blockers, we know, can cause a bronchospasm, and it's bad with patients in asthma because what happens? What do we do for patients in asthma? We give them that beta-2 specific or that albuterol, right? Well, if you're on a beta blocker, the albuterol is not going to do anything. It's going to block it, and they're going to be bronchoconstricted, right? So diuretics, we talked about 2 diuretics. We talked about Lasix furosemide. We talked about hydrochlorothiazide. We talked about what ions or electrolytes they reabsorb. So maybe that causes hypotension or some circulatory collapse. Maybe they're hypokalemia. So your ACE inhibitors here for some hypokalemia, well, dig toxicity. So I actually put this on the wrong slide, but this here, what you're seeing is the EKG of somebody on digitalis. And how you know about digitalis toxicity is they have that yellow hue to their vision. And also what you'll see is kind of like an ST segment that isn't normal. It kind of has a downward slur. You have an inverted T wave, and then you'll come up and have another T wave. So if you see this tracing in your 12 lead or on your EKG, that's pretty indicative of digitalis toxicity from maybe some hypokalemia or some other reason, right? People who are on bipolar, they take lithium, and lithium is excreted entirely by the kidneys. So again, if you're bipolar manic episodes, should be treated with something other than lithium. If you're elderly, hopefully they can get that under control. These people, there's a very narrow therapeutic window. And so depending on how much they give and if their kidneys aren't excreting it, they can actually go into a coma and they can actually die from it. And then as Kristen Woodward said before, with our psych lecture, that other antipsychotics can cause sedation, anticholinergic effects, which is tachycardia, dry membranes, vision disturbances, and extrapyramidal side effects like twitching or tardive dyskinesia. All right. So this year, I think I'm going to wrap things up with here. This is drug and disease interaction. So with this, if you have glaucoma and you're giving somebody atropine for whatever reason, it actually puts somebody into acute glaucoma phase. Right? If somebody has CHF and they're on a beta blocker, you're going to have decompensated CHF because you're going to decrease the cardiac output. If somebody has COPD and they're on a beta blocker, we know that that's not going to work well because we usually have to open them up and you can actually cause a bronchospasm. COPD and opiates can cause respiratory failure, but usually in high doses of the opiate. Hypokalemia in digitalis can have some dysrhythmias, as we already saw. If you have peptic ulcers and NSAIDs, it's going to cause maybe a GI bleed or later on. Peptic ulcers and anticoagulants will also cause a GI bleed. If you have prostate enlargements and you're on atropine, you actually will not pee and you will have urinary retention. And if you have any sort of heart conduction disorders and you're in a tricyclic antidepressants, you will actually go into a heart block. So everything we do in the decreased systems of the body make it that much more important for us to kind of talk to the patients, figure out what's going on, and be very careful in how we treat these patients moving forward. So I think we have geriatrics next week. And when we do, I'm just going to give you a bunch of case studies. And with this case study, we're going to do some differential diagnoses. And I want you guys to figure out what's going on with them so we can kind of make it more interactive. But before I did that, I had to make sure you understood how the body changed and how the body works. And with that, I'm still not to Joe Mistovich status because I have 5 minutes left. So does anybody have any questions? All right, between Dan and myself, I think we put everybody to sleep.
You all out there still?
We're here.
All right, nobody get out yet. I didn't do attendance yet. Stand by. dots won't open up. There it goes.
All right, so for next week, February 15th, we have Teleflex is going to talk about EZIO, different places to put it in. They actually gave me a handout that I'm going to forward to everybody, and that's going to give you an extra link to go to and get extra CE hours on your own if you want it. Justin Cooper is going to talk about helicopter utilization outside of the realm of emergency transport. Maybe you need a surgical airway, maybe you need some blood. He's also going to fulfill some landing zone safety requirements that some agencies need. Following that, we're going to have Meridian Healthcare talk about the well-being of the EMS provider and also the first responder. I know that several police agencies need some continuing education on well-being as well. So if you have any of the police departments that need to get this continuing education, please forward them the invites in the link and let them join in on this. Dr. Cafaro and myself are going to talk about sports injuries, and then we have one more hour on case presentation for geriatrics. February 22nd, that's when we have Paige Wolfberg and Worth. We're going to talk about EMTALA, whose responsibility is it with extended ER wait time. We're also going to talk about really anything that you have the last hour. They want to talk about whatever your legal questions are. Follow that by the following Thursday with EMS documentation by Captain Renee Waldo of Vienna Fire Department and Attorney Chip Comstock talking about other EMS issues. And then finally, we're going to wrap everything up, and that'll be our 60 hours of CE, and that's going to be trauma review with a trauma surgeon with different cases, how they got brought in by EMS, what they did great, what we can improve on, and what the patient outcome was. So that's your tentative schedule, and that is your schedule for through March 1st.
All right. Well, thanks a lot, Larry. Again, very informative. Appreciate the prep work and everything that goes into putting on these talks. Are no questions, comments, concerns out there, guys? Okay. Just as an aside, I encourage you all to. Steward Health is going to be doing our Steward of the Community awards at the end of EMS week again this year. We're bringing it back after a couple of years. So you'll be seeing flyers come around and things like that. If you have people that you might want to nominate for different categories, please get those into me by email. Another thing I would also like is, I know we have a lot of people from all over the state and a couple other states. I'd appreciate it if you'd email me, send me a picture. Send me a picture of one of your trucks, your station, your patch, anything you want, something that represents, where you're from. I'd appreciate that. We're going to try a little project at the end of this. So if you're interested, please send me some pictures of, even if they're action shots, just be aware of HIPAA and patient concerns. So I guess if there's no other questions or anything like that, we'll let you folks go. Right on time, 9 p.m. Good job, Larry. Have a good night, everybody. Thanks for spending some time with us. I appreciate it.